the entire screen, okay? We want to talk to you during this meeting, so please type everything that you want in the chat box. Where are you from and all of these. And please don't forget to click on all attendees and panelists. In this way, everybody is going to be able to see what you are typing. And if you have questions for the panelists, for the speakers, please type on Q&A chat box, and we are going to answer during the meeting. We hope all of you can get the best from all the speakers. Our next activities on this Wednesday, we are going to have continue on the ICU topic. We are going to talk about monitorization on the CICU. We hope all of you can join us. On Friday, we have our morphology series of Dr. Anderson, and next Thursday, we are going to have our big webinar about surgical update. We hope all of you can join us. So please feel free to type everything, make questions, and enjoy today. Sasha.
Yes, Grace, thank you very much. It's a fantastic option and opportunity for all the people to have such amazing parterre of colleagues coming from all around the world. And I think that I don't need to add something. So only welcome to all of you, and I give my real boss, Gil Bernowski. So now it's time for you.
Hardly. All right, let me just put a few things up. I'm really very excited about, is that popping up right now? You see those?
Yes.
Yes.
Okay, thank you. I'm really extremely excited about this first webinar in cardiac intensive care. It sort of has, the program's evolved really quite organically. Early on, Paul Kecchia, who you'll meet shortly, and I were discussing about the similarities and differences in our practice over the years. And we put together a faculty to try to tease out what's truly center specific and evidence-based. So I just want to introduce the faculty to you. First is Neil Spenceley, who's a consultant pediatric intensivist in Glasgow, who's been in practice in cardiac intensive care for about 20 years. Here's the aforementioned Paul Kecchia. He has seen various practices at Children's Memorial, Loma Linda, at St. Louis Children's, and now has been at Texas Children's and has been in practice around the same time, as well as Laura. They're colleagues now in Texas Children, but Dr. Laura Shekerdemian has been in many locations in the Commonwealth, including at Great Ormond Street Hospital for Children and the Royal Children's Hospital in Melbourne. John Berger is the medical director of our cardiac ICU here at Children's National, runs the pulmonary hypertension program as well, and has spent his entire 27-year career here at Children's National. And then finally, my name is Gil Warnofsky. I'm one of the cardiac intensivists here also at Children's National. I spent 10 years in Boston and 18 years at CHOP, and then 3 in Miami. So I've seen lots of different strategies over those years. And I think we're all going to talk about what's the data and what's the dogma. But we looked at this group and said, well, we're clearly missing some important elements here. This is Luciana, let me be sure I get this right, Luciana. Luciana da Fonseca da Silva, who's a cardiac surgeon currently in Pittsburgh, and spent most of her time prior to the 4 years she's been at Pittsburgh in Sao Paulo, Brazil, along with our co-boss of the Congenital Heart Academy, Grace Van Leeuwen, who has been also at Sabra Hospital Infantil and now is in Sidra. And they've been in practice, as you can see, 9 and 15 years. But we clearly needed surgeons, and Luciana's a surgeon, and we needed this guy, which I don't know if anybody has seen this picture of Sasha. I don't know where I found it, Sasha, but you look so young and happy and enthusiastic. I really love it. Sasha is the co-founder of the Congenital Heart Academy with me, and this is all his brainchild. I have to completely admit the option to be able to do this, and with COVID now being here. Sasha has worked in Taormina for the last 16 years, now part of Bambino Gesù, which is also affiliated with the Bambino Gesù in Rome. This started with the congenital heart campuses in Taormina. There we are in 2017 and 2019 down on the bottom. And I have to tell you, these trips to Taormina have been one of the highlights of my professional career. When COVID hit, we realized that we couldn't do this. And Sasha said, well, why don't we just put this on for free? And we've really learned a lot that there is a great need for these types of educational seminars, particularly for people that don't have the luxury of traveling abroad. We have seen over 100 countries per webinar join in, and that's across multiple time zones, which is really a tribute to people's interest and the need for this. If we can do this again in Taormina or somewhere in Sicily, I strongly recommend you all come. It's a wonderful location. The faculty's on the left. We have small, intimate conference rooms to discuss things. The city is absolutely spectacular. On the left is where we had coffee in the morning, every morning. It was just such a great way to start a conference, not in a classic convention center. And this is our team from Children's National, and we just had a wonderful, wonderful time. So I'm going to ask you all, we're going to start this with a poll. This is completely new. You all are guinea pigs on seeing if our new polling system works. So if you could take out your phone or maybe open up another browser window and type in ahaslides.com/CICU. So that's ahaslides.com/CICU. This will be on the rest of the slides that I show you, but I'm going to just switch my screen for a second here, and hopefully this is going to work. Let's see, you should have the option at this point to see this first slide. So people, how should we have Dr. Shekhar-Demian, which picture should we use, or should Texas Children's Hospital use for their promotions of Texas Children's Hospital? Now that may have been too fast. We'll give time people to maybe log back on. You could see up at the top, it says ahaslides.com/CICU. I'm going to actually open it up again for another 15 seconds if you'd like to try. Now we have, oh, this is great. So we have 144 people. I'll do it one more time. I'm learning this as well as you all are, so this will give you an opportunity to vote. Laura, it's pretty close. Which one they should use? People may want to vote on the Christmas outfit, I'm not sure. And the picture in the bottom is actually from Cannes, when the World Congress of Pediatric Cardiology and Cardiac Surgery was in Cannes in 2009. All right, so what we'll do now to start the real poll is this one. So if you could open up your app, there's about, well, it's reassuring to see that most of the people on the cardiac ICU seminar are cardiac ICU caregivers. I'll try that one more time. So we have about 200 of you have been able to vote. And you can see as the votes come in, it doesn't really change very much. Grace and team, what do you think of this new system? Does it seem to be working okay from your end?
It's very good.
Yes.
Just the only thing is that only 200 people already logged in. If you have any difficulty to log in on the system, please type on the chat box and we can assist you on that, because we have 1/3 of our audience logged in so far. But
Okay.
this is very nice.
Yeah, so again, if you missed the very beginning, the logon is at the top, ahaslides.com/CICU. All right. The one thing that I don't like about the system, Grace, is that you have to sort of switch back and forth. So maybe you could tell us how you came to learn about this webinar. I'll give you a little more time on that one. This helps us determine where we put our efforts. You can check more than one, by the way, if you want to go back and check more than one way. For example, I know I may spend a lot of time posting this on LinkedIn, and if I see 12 people came from that strategy, I may not want to do that. And Grace told me there's a lot of individual WhatsApp groups. And then the last one I'll do here. And then we'll move through the poll relatively quickly. So be ready to answer the next questions, please, relatively promptly. So this is helpful. Okay. Okay. This is sort of a fun thing. You're going to get the option to type in 3 words. What are the 3 words that describe why you take care of children with heart disease? I wonder if that's working. Here we go. These word clouds are very interesting. So the certain words that you type, you can see that many of us are calling our profession challenging and that we do it because we love doing it and that it's rewarding. I was curious how this word cloud was actually going to work out with almost 400 people now putting their words in. I'm really glad I don't see money on there, but love clearly has clearly been the one that has been most consistent here. It's a neat little feature, I think. I kind of like that. Okay, next, tell us where you live. This is a new time for us, so it's a little bit later than usual for those over in Europe and east of Europe. I'm curious, right? We usually get mostly from South America when we have the earlier time, but this should be about the same. All right, that seems to be just about done. And Grace, we'll save these and present them on the website and whatnot. Okay, another word cloud. What do you hope to receive from this webinar? Did I not open that? Oh, okay. Equipoise, excellent. No, Sasha, this certainly goes with our mission, right? It's nice to see what, and we'll be able to look at this in more detail after we have the opportunity to download the various things. But knowledge is clearly what we're all here for, and certainly everyone on the faculty. I can speak for all the faculty, but I really want to thank them all for volunteering their time, not only the 3 hours today, but for all the things that they do to prepare for these talks. Okay, so this question is, after cardiac surgery in a neonate, and Neil, I hope this may tie in with your talk, I typically obtain laboratory studies on a schedule, such as every 4 hours or every 2 hours, a so-called surveillance plan of obtaining labs. Certainly know in our center, it's a common question after we round or do cyanide. How often would you like blood gases or hemoglobin or what that might be? So it looks like 4 out of 5 of us generally will do things on a routine basis. The other thing that's been interesting to me as I look at the poll is that once the first 20 or 30% are in, the percentages don't change very much. So I think that's how they predict elections, when they just get a small number of the vote in. So how often, so here's a question, you have a baby that's doing well after an arterial switch operation. How often would you draw blood gases in that patient? Well, here's a great example of data or dogma. Right? I don't know, and maybe Neil, you'll share some light on this. Does doing what the plurality of us do, which is draw blood gases every 4 hours, is there any data to support that? I don't know. Our next one is the same question, but now we're dealing with a 1-day-old who just had repair of obstructed total anomalous pulmonary venous return. All right, so that's changing around a little bit. It was doing well, doing well. Interesting, huh? And we're getting that same sort of 15 to 20% who don't order blood gases on a routine basis. And I'm interested to hear what that exactly looks like. And now let's talk about a patient that Laura is going to talk about later, which is now you have a baby who's had a good repair. This is, say, a 3 or 4 month old of tetralogy of Fallot. So it looks like many of us have settled on every 4 hours is right, or at least that's how we do it. And this will be the theme as we move through this entire webinar. All right, how about this one? So now we have a baby and they've come back from an arterial switch operation. And I'd like you to think about the patient should have, from your perspective, should have either you could check as many as you want, percutaneous central venous line, a right atrial line, a left atrial line, a pulmonary artery line. Do you think they should have open chest and delayed sternal closure? And do you think they should have routine peritoneal dialysis or dialysis catheter? And I'm really curious to see what when we get to this, what's going to be the difference between our panelists of 8 people from different practice settings who've been trained in different practice settings. It's interesting that if this is correct, I'll assume that people want to know the central venous pressure either through a percutaneous central venous line or a right atrial line. So that's over half of you. That suggests to me that half of you don't have a central venous line. That'd be interesting. Maybe we'll ask that question again a little bit later, and I'll give it another 9 seconds, okay? See if people would like to answer. But as you see, it doesn't change very much. Okay, now take that same question, but now you've got that 1-day-old baby who just came back from obstructed pulmonary venous return repair. Now we start to see the PA line come up, as I suspected we would, a left atrial line, and I know that Dr. Van Leeuwen is going to speak about that as we move forward. And we've got 151, we'll just do this just a little bit more. So a few more will suggest having it after total anomalous pulmonary venous return. Same thing with pulmonary artery line compared to an arterial switch. And we're getting sort of a consistent 10% or so for delayed sternal closure and a PD catheter. And I think that that's also very lineage treated coming out of the Melbourne group originally. Maybe Laura can talk to that in a little bit. Same thing, but a 3-month-old healthy baby who's had a good repair of tetralogy of Fallot, has a good intraoperative TEE with no evidence of any residual stuff. So the numbers of elective delayed sternal closure way down, about half as many people for a PD catheter, a PA line in 5% of tetralogy repairs, and an LA line in only 5%. You can tell the words that I use based on my own bias here. And we can maybe show these results later on as we move through the presentation. Okay, after an arterial switch, routine monitoring in the ICU, non-invasively. Should they get an EEG? Should they get NIRS, near infrared spectroscopy on their head or on their abdomen or on their kidney? Should someone with coronary transfer get an EKG? That's a surprisingly low number to me, so I'm skeptical of the, yeah, I know what's happening here now. This is giving us percentages, and I'll go back to these numbers. This is adding up to 100 as opposed to the raw numbers above it. So I'll take a look at that during the break, and I can resend it, because I would imagine that most of us, if not all of us, are getting an EKG after this operation. So let's just get the votes in so that then I can redo the numbers. And thanks for being guinea pigs on the first time we do this. Same question, but this time with a baby with obstructed veins. And again, I don't know what the raw numbers are, so I'll let people vote. So this has now been, let's see, 160 of us have voted, 180 of us have voted. Let's do it one more time. And thanks for putting up with this. We'll be sure we catch up our time, and I'll give everybody the raw numbers for these later on. I should be able to make a presentation pretty quickly. Okay, tetralogy, same question. Those are going to be the three cases we discuss in the second half of this program. So we're going to be talking about an arterial switch operation, a tetralogy operation, and obstructed total veins. All right, so I've learned a lot from this presentation. I'll get it fixed for, Grace, I'll get this fixed for the next couple webinars, okay? And as you're seeing,
me too, yeah. But that's it. We don't know exactly when we have people, when they can answer multiple times the same question, we don't have the correct numbers.
We don't get the raw numbers. So again, there's so many different medicine cocktails at different institutions. So it will be interesting to see when I get these raw numbers, what you would use after a neonate. This is, again, a neonatal arterial switch operation. So we have, well, some people are routinely using nitric oxide. Interesting. We don't routinely have access to levosimendan here in the States, but it'll be interesting to see how many use that. Paul and Laura, do you have routine access to levosimendan at your place?
No, special access we had, and we've now run out officially. I think we've used our last dose.
Okay. And if any of the panelists would like to chime in with a comment about that, unmute your mic and please say.
We use quite a lot in Brazil. Here in Qatar, we don't have it, but in Brazil we have, and can be a dogma, not a data. We know that, but it seems to work pretty well.
Good. And for those of you who've come in late, please, if you can open up another browser or on your phone, open up the link to ahaslides.com / all capitals CICU1. Again, what medicines for a baby that's just had obstructed TAPVR and is what we would call doing well. I was wondering when nitric oxide was going to pop up on that. Okay, starting to come up now. Boy, a lot of people like Gilrenon. All right, I'll just give everybody another 5 seconds, and we're just about done with the poll, and I think this will inform the discussions that we have later on. So we've talked about our medicines, we've talked about our monitoring catheters, and then here is our tetralogy child who has had a good repair and is doing well after the tetralogy repair. Milrinone seems to be dominating just about all over the place. It's interesting how, especially for the younger generation, this medicine was not used until probably the mid-90s and was thought to be, the mid-2000s, and was thought to potentially be very dangerous based on some adult work. So it's interesting to see how that has changed. So Laura, maybe I'll try to get you the numbers, and Grace, I'll get you the numbers so we can internalize this as we give our talk. Okay, now I just have a couple questions about transposition. So at what percentage of patients in your institution receive a balloon atrial septostomy for transposition of the great arteries with intact ventricular septum? Very interesting. Couple more questions about transposition. I'll give people a little bit more time to vote. The majority of us work in cardiac intensive care, so this should be something that we certainly see, as opposed to something that happens in another unit. Okay. And what about the percentage of patients with transposition with a ventricular septal defect? Less likely. It's interesting. We had a baby in our unit last week who was mixing quite poorly, but I think that that's uncommon. So less common transposition VSD as we would sort of expect. All righty. And then what's the typical age for surgery at your institution? Transposition, intact septum.
So this works well because this is only a single answer for each person. So this works very well.
So we're settling somewhere with a, it's interesting the number of people that are doing them greater. So again, just to remind you, transposition, intact ventricular septum. So in the first week of life is most, toward the end of that first week. Give just a few more seconds for people. And what about transposition VSD at your institution? This might be skewed a little bit more rightward, would be my guess. That's pretty much what I expected. Just so people are aware, and I'll put the link in the chat box, a recently published study out of Toronto has sadly shown that this practice of waiting longer in kids who so-called can wait is highly associated with lack of brain growth between birth and the time of the arterial switch. And that delaying the arterial switch operation much longer than 2 weeks is probably not worth it from a brain perspective. And we're going to talk about that from an ICU perspective in just a second. And then finally, I put yours in pink, Grace. Which of the, do you mind if I do your question, Grace? Is that okay?
Yes, of course.
So you can choose as many as you would like here. And here I have the raw numbers, so I got it right here. So which of the following statements are true regarding a baby with obstructed TAPVR? On inhaled nitric oxide is contraindicated pre-op. Is that true? Prostaglandin is contraindicated pre-op. Is a surgical emergency. Is that true? Obstructed TAPVR. An LA line, and Grace wanted me to put, is mandatory for postoperative care. 28 people here. A residual ASD or PFO is mandatory. And again, a peritoneal catheter is mandatory for postoperative care. So more people. So again, we're getting, this is 7 out of almost 200, 8 out of 200. Again, about the 4 to 5% of people who are using PD catheters in our audience. Thank you all for letting us try this at the beginning of this webinar. We will fix it and make it better for the next one. And with that, I'm going to stop the screen share. So with that, I'm going to turn this over to my good friend and colleague, John Berger. When I asked John what he would like to talk about in terms of data or dogma, his eyes lit up. And he said, I want to talk about the high-risk intubation. We were going back and forth, myocarditis and whatnot. But then he was quite clear he wanted to use as an example the baby with pulmonary or the child with pulmonary hypertension needs to be intubated. So John, I'm going to turn it over to you.
All right, thank you, Gil and Grace and Sasha for letting me participate in today's seminar. So as Gil said, I'm going to talk about a high-risk intubation. Let's see if I can make this move forward. I have no disclosures relevant to this talk in terms of finances. This is my opinion based on experience intubating patients, and I think is probably based on dogma. The one dogma I like the most is epi in hand is worth 2 vials in the code cart. And I carry epinephrine with me in the ICU as a talisman to ward off the evil spirits. So I'm going to talk about the risks of intubation and anesthesia in patients with pulmonary hypertension.
Your slides aren't up, John, just so you know. Your slides aren't on, just so you know.
Oh, okay. There, let's try that. You see them now?
Yes, sir.
All right, great. So I'm going to discuss the risk of intubation and anesthesia in patients with pulmonary hypertension. outline a framework for mitigation of that risk, and focusing on the cardiovascular risks. The technical details of handling an airway and handling a tube are not my focus. So how does it go wrong in intubation? Well, we have difficult mask ventilation that can lead to problems, difficult airway, hard to intubate that can lead to problems, hemodynamics, and special circumstances. Most checklists of intubation that you'll download from the internet or in review articles will only focus on 1 and 2. And a typical one from up to date, not a single mention of vasoactive agents, what we deal with in the cardiac ICU. So this is, my checklist always includes things like epinephrine and ECMO. So where are the real high-risk patients? Where are those conditions requiring extra care? Well, pulmonary hypertension, myocarditis, coronary disease, pericarditis, and heart transplant. In terms of congenital heart disease, it's really about valvular disease, specifically mitral valve disease and aortic valve disease, and then also Williams syndrome, which I think frightens most of the anesthesiologists I know the most, mainly because of this idiosyncratic reactions to anesthesia. So how much risk are we talking about here? In pulmonary hypertension, which is the focus of the rest of this talk, the mortality risk associated with anesthesia is measurable. It's somewhere between 4 and 8%. That compares to the general pediatric population where the anesthetic risk is 0.02%. So a 1,000-fold increase in risk in pulmonary hypertension patients. Additionally, they have a risk for significant events, including cardiac arrest. I also show you the data for congenital heart surgery, which is hovering now around 2.4%. And the most recent cardiac catheterization studies in patients with pulmonary hypertension, the risk of dying is twice that of cardiac surgery. So one of the things that's important about all of this is that treatment of pulmonary hypertension patients and sick patients with cardiac disease needs to be in expert hands. And the reason it needs to be in expert hands is so that minor events don't become major disasters. I use this nice study looking at 77 patients undergoing cardiac catheterization and their anesthetic management. Almost half of them had bronchopulmonary dysplasia, and about a third of them had congenital heart disease. The median age was 6 months, and we looked at 148 procedures. And what you'll notice is that minor events are relatively common in this group, so that almost 40% of the patients had significant hypotension, 20% had significant hypoxemia, but very few of them had major intraoperative or intraprocedure events, such as cardiac arrest, a PH crisis, or failed extubation. The other important thing is that many of these PH patients will have major postoperative events, including cardiac arrest, respiratory failure, and death, which may have antecedents in the procedure. And again, these are diagnostic catheterizations with no interventions. So how does it go wrong in right heart failure? Well, there are several things that are happening. First, there's a reduced systemic vascular resistance with a limited ability to increase cardiac output, which leads to reduced coronary perfusion and ongoing myocardial ischemia. There's RV systolic dysfunction, which increases tricuspid valve regurgitation frequently and reduces LV filling. There's further diastolic dysfunction with RV diastolic hypertension, and because of the interventricular septum, that compresses the LV, further limiting cardiac output. If we look at this graphically, intubation raises right atrial pressure, and if you are normal contractility, you go from this graph to this point, and a fluid resuscitation may help you restore cardiac output. However, if you've got depressed contractility, the addition of fluid doesn't really increase your cardiac output. And what you need it to do is increase inotropy. So a dose of epinephrine versus a volume bolus. This is further emphasized by the fact of what happens to the RV during diastole with a fluid bolus. You give a failing right ventricle a fluid bolus, you increase the size of the right ventricle, increases the right ventricular end diastolic pressure, the septum, interventricular septum shifts more to the left, impairing left ventricular filling and reducing cardiac output. So again, epinephrine, not volume, may be the way to go here. So what are some of the strategies to mitigate intubation risk here? Well, the general approach that's taught to most people is ensuring adequate muscle relaxation and anesthesia, hemodynamic stability, and then a rapid sequence induction where you move judiciously from pre-oxygenation through intubation and confirmation. I will submit that that's different than what should be practiced in the cardiac intensive care unit, what I call the cardiac intubation. Most of the goals are the same, except with a cardiac sequence intubation, there is incremental induction with the anesthetic agent and careful assessment of the hemodynamics after every dose. These are the characteristics of an ideal intubation drug. Rapid onset, limited effect on hemodynamics are probably the two biggest ones for this discussion today. A mention about the pre-medications. These are the typical list. What's usually not found on the list are large needles in case you're dealing with a pericardial effusion or having ECMO standby for your highest risk intubations. I know that in patients with myocarditis or severe RV failure and pulmonary hypertension, frequently the co-conspirator, the colleague who's in the room next to me during the intubation is a cardiac surgeon prepared to put the patient on ECMO if things go south. And then anesthesia and neuromuscular blockade. These are the common anesthetic medications, popular combinations at the bottom. I used to be a person who liked pure fentanyl. Some prefer pure ketamine. I am now, my favorite combination is now ketamine and fentanyl. I think a couple words about the dosing. So the formulary dose for ketamine is 1 to 3 milligrams per kilo IV push. When I'm doing a cardiac induction, I use a much lower dose, 1/4 to 1/2 milligram per kilo, and repeat as needed. I relate an experience I had not less than a month ago where we are intubating a patient with dilated cardiomyopathy who is progressing to cardiogenic shock and eventually worked his way to a ventricular assist device. He looked relatively well and was talking to me, so I doubled my usual dose of ketamine. After a delay in the onset of action, he went completely apneic and would have had a cardiac arrest had we not been prepared for rapidly moving and controlling him. So again, much lower doses than typical. Why do I like ketamine so much? Because it has minimal impact, in my opinion, on hemodynamics. And I'll just share this one meta-analysis looking at ketamine and hemodynamics in children with congenital heart disease. And with the pooled studies, there is no difference in SVR, no difference in pulmonary vascular resistance, no difference in cardiac index or mean arterial blood pressure, making this, for me, a very nice drug to use in intubation of high-risk patients. So hopefully in that short presentation, we've reviewed the cardiopulmonary changes of intubation. We've given some thought to cardiac considerations, and at least my drug choices and my dogma about what to use. Thank you very much.
Thanks, John. If you could unshare the screen, that would be terrific. Maybe, Paul, do you want to comment on John's presentation or anything that's different in your practice?
Yeah, I'd love to, because you're actually changing my view a little bit, because, you know, again, this is pure dogma, right? And the dogma for me is also experience, where as a fellow, I watched one of my great co-fellows, I think we, the two of us, added to a child's unfortunate demise by using ketamine for an intubation. It was probably more just experience, and we didn't have any, and it was in the middle of the night. But because of that, the dogma is that I scared myself off of using ketamine for any intubation, right? You know, I'm not going to get burned twice. So it's interesting to see that last slide that you put up with the actual data, because I use just a little whiff of fentanyl. I use atropine in everybody, no matter how big or what your heart rate is going in. And I view it as, if they need some therapy afterwards because they remember it, that's better than me doing them harm during the intubation and ending up on ECMO or dead. So that's my take on your data and dogma, and I want to change my practice a little bit now, thanks to you.
There's two other intensivists on here. I just really quickly, Laura and Grace, anything different from Paul or John?
Ketamine is my favorite for sure. Fentanyl, I had the same experience as Paul, but it was a fentanyl, a thorax rigidity, and the patient almost died. So with a rapid bolus of fentanyl. After we learned, but I was a fellow, and it was it was not good. So fentanyl is not my favorite for sure. Ketamine, I do for all the severe patients.
Laura said she has nothing to add and she's unable to mute.
Okay, just a comment, Paul, about the lack of. Go ahead, Luciana.
I'd like to make some comments. I really loved your presentation, because as a surgeon, I'm always seeing people thinking about giving volume to right ventricular function, and I completely agree with you. We need to give also the epinephrine as a support. About the ketamine, most of the studies are done in patients with normal heart. As we know, ketamine didn't decrease the cardiac index, because she makes the heart accelerates a little bit. So keeping but it is also depress the myocardium. So I completely agree with you. We can use in heart failure, but with cautions to avoid cardiac arrest. I had an experience. Juvenal told I am 9 years in practice, but actually I'm more than 21 years in practice.
I apologize, Luciana. Thank you.
Just to make you look younger, Lou.
Yeah.
I wish I was 9 years in practice too. That's for the panel. There's a number of good questions here about etomidate in this situation, and why don't we answer them in the Q&A box? Unless, Grace, if you have something majorly different, we probably should move on. Laura, were you able to unmute yet? Yes? Okay, great.
Yes.
All right, so
Two comments.
Sure, John, go ahead.
Just two comments. Number one, I would be cautious of not having any amnestic on. We had a patient who recalled his intubation, and it really gave him significant PTSD for a long period of time. And, you know, while I like ketamine, I think that the drugs that you have the most experience with are the best ones.
Thank you. I just got a text from Neil, who was supposed to be our next speaker. I'm going to close these and see if he's been able to pop on. But apparently the internet has gone down throughout where he is in Glasgow. So he's trying to get to another location, so that we're going to flip the order around, Paul, if that's okay with you. And we can heckle Neil. We can heckle Neil when he gets back later, assuming that he does. But my good friend Paul Kecchia, who's at Texas Children's Hospital, needs no introduction to those of us who do cardiac intensive care. And talk about something that is. Oh, Neil, you're back. Let's see if he can speak. Neil. Hello. Okay. Paul, you want to go, or we should go with Neil? It's up to you, Paul.
It doesn't matter. Whatever's easier.
All right, Neil, if you're ready to go, I'm glad you got your internet back. Why don't we go with your presentation, okay?
Okay, sorry, I'm not entirely sure what happened there.
Just in time. Of course, we were going to ask where you had gone in Glasgow when there were multiple other options, but I'll leave that. I'll leave that.
There's plenty of whiskey and things certainly to be had. So I'm just going to see if I can join and share my screen. Okay, can you see that, Gil?
Looks great, Neil. Thanks.
Okay, good. So thanks very much, Gil, for inviting me onto this talk. So I've done a sort of a version of this talk before, so it's updated, something I did for Paul a while ago. So monitoring, it's sort of to observe, check the progress or quality of something or somebody or some patient over a period of time, keep that under systematic review, and sort of maintain regular surveillance over time. So I've done a bit of sort of looking around. And your question was well made, Gil, about what is the amount of evidence out there, and what do the majority actually do with regards to the amount of monitoring that people do, particularly after the post-operative cardiac patient. So there is absolutely no clear consensus. And I wondered about whether it was possibly due to widespread heterogeneity of our patient population and also the vastly different resource allocation that is throughout the world. So I suppose, why do I need monitoring? Well, I need it for a number of reasons. Window into a child's physiology. I think it gives you a heads up, but at the same time, in this increasing world of demand to know every answer, I actually yearn for simplicity. So if you look at the ideal monitoring, well, it's cheap, it's easy to access, it's easy to use, it's easy to understand. You understand the knowledge that it's giving you. It's hopefully continuous. I know this is a sort of talk on the sort of erring on the invasive, but actually, ideal monitoring would be non-invasive. And one would hope that it allows you not to give you a number of the balance between DO2 and VO2. My QPQS machine broke years ago, but it augments what you already do at the bedside and perhaps improves the situational awareness and communication of the grave nature or the improving nature of the child that you and your team are looking after. So Jean-Louis Fanzant, in a great paper, which has sort of stood the test of time, the relationship between VO2 and DO2, is a very important concept, but no monitors are alone is ideal. And I think that's the sort of the important recurring theme, that one number is not what we should be aiming for. It's a collective decision and idea about what the patient is doing, both with visualization of the patient and the monitor, but also your team around you. So I was just going to stick to a few things that may help you with your VO2 and DO2. And I'll go start with lactate. So once thought to be a waste product of anaerobic metabolism. But in fact, if you think about it, it's unlikely that something has been in the world for millennia and it's not doing anything. It's not there for a reason other than to scare you at 2 o'clock in the morning when you see a lactate of 5 on your blood gas machine. There must be some other reason it's there. So it now seems to be sort of, continuously produced, both interestingly in aerobic and anaerobic conditions, about 1500 millimoles we produce every single day. It's a major energy source, it's a major gluconeogenic precursor, and also there is increasing evidence that it may be a signaling molecule, which may well give you a heads up that things are sliding, because one of the problems with lactate is its delay. Not the ideal monitor. It's not continuous, although that has been looked at. It is invasive, doesn't specify what disease you're dealing with, nor indeed the treatment. It's not readily available, and it is indeed a latent detector of hypoxia, but it does have this. unlike any other monitoring, in that it has a number which, if it goes above, then you should probably do something about it. And that doesn't matter if you're me, the Queen, anybody. 2 is not right. So a little bit about the physiology. Well, I mean, as glucose comes into the cell, it's transferred through glycolysis into pyruvate. There's a little bit of energy generated, and then it goes into the TCA cycle. And that's all well and good. Sadly, there's no cellular, supply of oxygen that you can hold on to. There's no there's no, what's the word I'm looking for? Dump of oxygen. So if you get into the situation where the oxygen and its electron transfer capacity goes down, then you're a bit stuck. Law of mass action will say that the pyruvate will back up, glucose won't get into the cell, and you will get into trouble. The facultative and obligatory functions of your cell will dissolve. So enter our hero, lactate. So with the increase in acidosis, pyruvate goes to lactate, and then it is redistributed around the body in a very clever lactate shuttle mechanism, which supplies increased amounts of sugar to the cell. And as many of you will know, there's 2 ATP which are produced in the initial stages of glycolysis in the extramitochondrial area, and that will keep your cell alive. So the lactate comes and goes, but I personally think it gets a bit of a bad rap for a number of reasons, but I personally think it's an extremely useful thing to be looking at and measuring routinely. And here is the lactate shuttle, the redistribution of fast energy, allowing the release of sugar, which can be used to maintain that cell until we have realized that there is indeed established or impending hypoxia. And the 2 red circles are where the ATP is produced before pyruvate. So type A arising from decreased perfusion or oxygenation, that's probably the most common that we deal with, but also type B might be stemming from underlying disease or toxins, or potentially it may well be a signaling molecule. And here you can see that in the presence of ephedrine, even in the presence of adequate oxygen delivery, beta-2 stimulation will increase glycogen. That will then go to pyruvate in the extramitochondrial area, pop off to lactate, and then go into the surrounding bloodstream to scare fellows at 2 o'clock in the morning. The signaling is interesting, and that's becoming more and more evident that potentially we looked at children or anybody with lactates of greater than 4, and the general sense is that even if it's above 2, then that might be because of an ephedrine effect, and perhaps we should be looking at lactate and seeking other evidence of impending hypoxia before it's too late, because of the lactate that has been produced in a stressful situation rather than a hypoxic situation, which might well be on its way. My dogma about it is the association with lactate and lactic acidosis. People say that, they have got lactic acidosis, which kind of blames lactate to a certain extent, but actually there's not a great deal of evidence about that. In anaerobic conditions, hydrogen iron is produced, but it is not produced by the lactate itself, and it helps regenerate NAD, which is a transport mechanism, rebalancing the redox potential, improving intracellular acidosis, and the NAD can be used elsewhere. The problem, of course, of it is, again, its latency. And this is another good paper from Joly and Vincent talking about the area of luxury oxygen delivery and the fact that even if your oxygen delivery goes down, which is the red marker on the top, quite significantly, the lactate doesn't move because the DO2-VO2 balance is in the DO2 failure. However, if you get to critical oxygen delivery and the DO2 continues to fall, then suddenly your lactate has gone up. And we do know that, with hypoxia, then you're more likely to have increased morbidity and mortality. So what is the future of lactate? Well, it might be that we should be looking at doing it continuously. There's also some interesting stuff about maybe titrating in lactate or non-lactate solutions to keep the lactate at a stable level, because lactate can sometimes be protective and a very good source of energy, particularly for the brain. I suppose the thing that I also use very frequently, which is again the balance between DO2 and VO2, but is much more readily available and giving you a much better idea of that fall or the balance is SCVO2. So again, we've got luxury O2 independent of each other, but as it falls, your SVO2 will fall, assuming your VO2 hasn't changed, getting into your critical oxygen delivery. And then if it falls, there's no resources of oxygen other than it being constantly delivered. If it outstrips VO2, it too must fall. And this is a child that we had recently with on ECMO who had an arch repair switch, elected ECMO because of a very long bypass and high eye time requirement. And when we came to close the chest, which is in the middle of the screen, this is our clinical information system, all appeared to be relatively well, but we did have a capability to do continuous SCVO2 monitoring. And you can see, even though other parameters were satisfactory, the saturations fell quite dramatically to 28%. We reopened the chest and the child didn't undergo any sequelae and was well. But interestingly, due to the lactate actually over those period of hours just didn't really budge. I suppose one of the issues with SCVO2 is that it requires access and its non-linear relationship between a cardiac index and the VO2, and it's a nice paper by Shane in London Town. That said, one of the best resuscitations that we have ever done of a single ventricle patient in our unit was a child who was intubated, ventilated, had an arterial line, 2 cannulas and NIRS. And you can see here the information that we got, again, non-invasive and in real time, in conjunction with continuous clinical examination, and the child sort of improved extremely well, and in fact, and it did very well. Johnny Vincent, again, sort of a fall in SATs and hemoglobin can, be compensated quickly, but an increase in cardiac output by an increase in cardiac output, whereas the opposite really isn't true. This is my favorite slide about monitoring. We've got oxygen delivery, SATs, hemoglobin, cardiac output, the precursors of stroke volume, blood pressure, SVR, all the sort of things that I would love to have, and all the sort of things that I'd love my fellows to spout out of an evening. But of course, that's not really fair, because we don't have that, I don't have that, I don't have any of that, and I don't have that. That is often clotted, particularly in a resus situation. I don't really believe the blood pressure non-invasively, try the other limb. The saturations are not picking up, but I do have this. And I have it in 3 forms. I have it because of the chest leads. I have it usually the impedance or the saturation probe if it's working, but also you can find it just here, which is incredibly useful. And I think that this is another patient who was resuscitated who had SVR crisis. And it shows the saturations and the AVO2 difference. And as they came together, then the child was improving. But also, if you marry it against the lactate, it was falling, but crucially for me at the bottom, the heart rate was also falling during this time. So if you don't, what are the surrogate markers that you can use if you're using monitoring in a cardiac intensive care and you don't have multiple gas machines, you don't have the capability to have lactate, but you do have the capability to look at the heart rate. And for me, this is the thing that gets me out of bed at night, is a high heart rate is telling me that there may well be occult hypoxia somewhere in that child that we need to look at. The other dogma I have about monitoring is the information flow. So coming to the end of the talk now, the traditional way that you are looking at this is you have the patient, then you have the monitor, and then of course we have us. But with the amount of monitoring that we have these days, it's quite extraordinary. We have the ones that are fancy, we have the ones that are not quite easy to interpret, we have the normal ones. There's a monitor that's green around the gills, there's a one that's spelt wrong, and there's one that's incomplete. And I wonder whether sometimes it overwhelms our ability to interpret the data that's coming towards us. And potentially, even though we have this increased amount of monitoring, there is the potential to come disconnected from the patient. And perhaps we need to think more cleverly about how to improve sort of the monitoring, maybe identifying specific types of monitoring, simplify and amplify, which might give us something which we can then as a society use more consistently. But to finish off, it's the us bit that I'm really very interested in. I mean, if you have, you take Reason's Swiss cheese model, then people will think that more monitoring, more invasive monitoring will be helpful. Maybe we could block up a couple of holes in the top corner. But this is a static, non-dynamic picture. And my sense is that we don't appreciate that people, particularly at the front line, are constantly moving the bits of cheese around. They're opening and closing the holes in response to defective systems. And yet, if we add in yet another piece of monitoring, and potentially we rush it through, we're excited about it, and we don't train people correctly, and then there may well be further down the line something that is problematic and an incident, then quite often the people who have introduced the monitoring are not the ones standing beside the patient when they have deteriorated. So Adoko Andy said drugs, devices and personnel cooperate to deliver good care. So if you do have a monitoring issue, maybe we need to sort of divide it by sort of STS. And for me, that is going to be your socio-technical system. Resources are often scarce and often diverted to the afferent area and not the efferent pathways. So Pew systems monitoring. What about the bit beyond that? What about the capability of people to raise their hands when they're a bit worried? And this is the best monitoring system that I know, and it always will be. And you know, this was taken about 6 years ago. And the lady on the left-hand side is now an advanced nurse practitioner, and on the right is a senior charge nurse. The type of nurses you walk into the room at night at 8 o'clock for your shift and think, do you know what, I don't matter what's happening, it's actually going to be okay. And I'll leave you with two of my favorite quotes. One is from a fine Scot, Arthur Conan Doyle, you see, but you do not observe. And the other one is from a fine American, David Woods, resources are finite, but change and surprise never stops. How do you create the environment for your elaborate or unelaborate monitoring to filter the knowledge, the information that it has to the correct people at the correct time in a safe environment? So monitoring is to observe, check and the progress or quality of something or somebody or some patient over a period of time, and have that maintaining regular surveillance. And I don't think there is any one number in pediatrics that you're aiming for, apart from lactate. My sense is it's, are you trending in the correct direction? And what do I and my colleagues do? Well, we have standard invasive monitoring, CVP A-line, occasionally PA and LA line, 4-hourly paired gases plus lactate initially, dual site NIRS, but crucially, a clear two-way discussion with the bedside nurse and fellow to establish those dual feedback loops. And therefore, my sense is enhancing what monitoring you have, invasive or otherwise. Okay, thanks, Gil.
Neil, I'll share with what's coming up in the chat box and some of the individual texts that I'm coming in. That was just a superb, thoughtful presentation on monitoring that I think most of us take for granted. That, yeah, that's the right thing to do. I was going back and looking at the survey responses now with raw numbers, and I'll share them toward the end. But I had one question maybe before I open this up to some of the panel. And again, I'll ask the panelists to answer the questions and the participants to put the questions in the Q&A box, not the chat box, so that we can all type them and save them. So if everybody could take a look at that, that would be terrific. I think I heard Jim Tweddle once say lactate is too late, which was a good thing for me. And I did some work a number of years ago that unfortunately didn't have a market and didn't go forward, of an intra-umbilical line continuous blood gas monitor. And where do we stand now with continuous in vivo monitoring of some of the things we'd like to know before they already give us a value of lactate of 7 at 2 o'clock in the morning? Is there anything now on the horizon that you or any of the panelists know of in vivo real-time continuous monitoring of blood gases, lactates, or something along that line that can give us an early warning system?
I think the thing that I still like would to have a central venous catheter that has continuous oximetry. I mean, there is that availability, but they're difficult to insert. And the very children that you would like them to be in are the small children. And therefore, your artifact goes through the roof. There's the proximity of the actual venous wall, which can then interrupt the infrared light coming out. in the red light. And that's a sort of huge issue. I'm really interested in the sort of the potential for continuous lactate. But again, it's not using it in isolation. And I suppose the final thing, Gil, is do we think about, and there's a couple of people looking at this, do we think about augmenting a number of cardiovascular parameters to give us a single value, which we can then monitor continuously. And so just bringing together heart rate, blood pressure, NEERs, whatever, which may give us a little bit more powerful information and giving in that sort of ease at the bedside for nursing staff. Artificial intelligence, I suppose, is going to be the other thing. How do we marry that with artificial intelligence to give us the information that we require in a continuous way? So yes, I mean, the lactate I don't think is there yet. If we could get a better catheter that would do continuous venous sats, then I think that for me would be the way forward.
Thanks, Neil. I'm going to, just before the other panelists chime in, I'll take moderator's privilege. Ediometry is working, as you know, on an IDO2, which has only been which is great, but it basically shows you the probability of having a low mixed venous saturation, and we need that in kids that are not necessarily pink. But one thing that I wanted to talk to Sasha and Luciana about is you've got a whole bunch of intensivists on the panel, a whole bunch of intensivists in the audience. And I know we can sometimes have very different approaches as the ICU than the surgeon who's brought the patient back to the intensive care unit. I wonder if you could comment on the things Neil was just talking about. Frequency of monitoring. Do you get the sense I don't want it to be that, the patient's doing well, we monitor too much, and the patient's doing poorly, you didn't monitor enough. That's way too dogmatic. So Luciana and Sasha, you're here as the surgeons. How would you comment on that last talk? I'll go to Luciana first. You're muted, Dr. De Silva.
What kind of patient do you want me to comment on? The ASD patient, we don't need to monitor.
Go for it. You have the floor. You have the World Wide Web.
Yeah. For like TGA, I would like to monitor the left atrial line if the patient is not doing well. But as you remember, in the past, all the patients were with the chest closure after the surgery. So usually we didn't do that in the past, or we should do in a different way with a special catheter, not to bleed after the surgery. So it will depend on which situation the patient is in the OR. If it's a difficult case, I would go with NEERs, with mixed venous saturation, and scheduled labs. And of course, the clinical evaluation, that is the most important thing. As Neil said, a good nurse at the bedside is the best monitor that I ever know.
Yes, thanks, Neil, because this is a very interesting point. At the same time, I would like to ask from your experience how your
Sasha, you can't ask a question before you answer the last one.
No.
Okay.
Exactly about that. He's going to escape on this way.
No. I love to know from your experience how you change your approach, independent or dependent by the surgeon from the type of surgery and cardioplegia from the theater. What we use in our center, we use normothermia for all the children. So, and according to Gil and to my training, we use an ASD for all patients. So we never use left atrial monitoring. We will only use right atrial monitoring because we found not real difference, for example, in transposition or in tetralogy of Fallot. So I agree with the colleague that I really believe that the nurse is the best monitoring because they know what they do. I don't like inotrope. It means, again, trying to keep a physiological approach with the normothermia, del nido, cardio. We look the patient from another point of view. How long is the cross clamp time? You know, we are surgeon. We use NIRS only for patients with coming from total circulatory arrest. We don't use for routine patients that, as you say, are going well. We like to leave the chest open for transposition as a routine, but we leave 1 or 2 days, and if there is no real indication, we can close in the theater. We, as you know, in our center, we used to do mostly neonates. So our experience comes from this type of patient. I don't receive information by single ventricle patient in the poll. I hope you can help us with this type of patient in the next poll. But again, I would like to ask from your experience if you change your approach according to the surgeon which you work. This is my question. Thank you.
To clarify that, Sasha, it's if we change our approach in monitoring based on the surgeon or the operation. I want to be sure which one we mean.
Yeah, both.
Well, for at least I'll speak for myself that depending on who the surgeon is, I can generally predict what type of catheters will come back with the patient, which is dogma, not data, right? If within your same institution, that is variable. And that's been in multiple institutions where I have practiced. We have a ways to go for that. For the surgery, absolutely. And that's why I asked those questions differently about tetralogy, obstructed veins, and a routine switch. But I'd love to hear what the rest of the panel. We got John, Paul, Laura, Grace, and Neil. And then we'll move on.
I would only adjust the monitoring if you were the surgeon performing the operation. Otherwise, it's all the same regardless. But then obviously the operation counts. But if I also then could, I answered it, so then I can ask another question, right? And then I'll leave it open. But I want to ask Neil, because one of the things about this talk and one of the things we're not touching on is we're completely obsessing about predicting the negative thing that's going to happen. What about turning it around and saying monitoring actually can guide you to de-escalate your care faster than escalating your care, right? And that's something that I think gets underutilized, to say, this gives me reassurance, the patient that, oh, I was so worried about an hour ago is actually doing great, and I'm just going to move them along and get them out of our clutches and get them out of our grasp so they can get home faster. And I'd love to hear, so I've answered, now I've asked another, and then I'll stop.
So I think that it's interesting you say that, because I think that, you know, when we only ever talk about monitoring when it goes wrong, and we only ever talk about monitoring when it reveals something that we feel is incorrect, and then you kind of look at it and are introspective and worry that you've done something incorrect, and that really sort of focuses the mind on the wrong thing. And I think that with the emergence of resilience engineering and looking at what goes well, it might be that the narrative should be changing for most things in intensive care, probably for most things in life to a certain extent. We're in a society that is obsessed with things that go wrong, and we want an instant answer. But my sense is that looking at things that go correctly, which is most of the time, I think it was Eric Honagel who said, if something goes wrong once, it's likely to have gone right 1,000,000 times beforehand, except we never look at that. So I think you're right. You know, we should be, you know, we look at children who, you know, the cardiac that arrested, and you spend a huge amount of time looking and dissecting through what could possibly have gone wrong, when in fact you haven't looked at the other 10 TGAs that have sailed through, and why is it that they did that? Why is it that nothing happened? Why is it that in this uncertain world, the child did incredibly well? So I think it's a very good point, and I think it's something which I'm certainly very interested in, is looking at what goes well, but also what went wrong in the context of what normally works. I think that there's, we need to present balance to our everyday discussions on the unit, because the vast majority, because you're the same. I mean, I'd imagine the most of the time when you come out of the unit at 8 o'clock at night or 8 o'clock in the morning, you've done lots of things. You've intubated, extubated, you've chatted to people around, the county, you've spoken to various firms, but blah, 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 but really nothing's happened. I mean, lots has happened, but nothing's happened. You can go home and switch off. But why is that? How have we managed to, negotiate uncertainty through the night? And I think moving forward, we're never going to get the perfect monitor, but it goes back to those two-way feedback loops with your staff to negotiate uncertainty. It's okay to be wrong and it's okay to be uncertain, but you can make together the best information work the best for you and for that patient. And the majority of the information that you get from patients, staff, etc., is very positive. But it's not the thing that we focus on. I think there needs to be a greater balance. So I'll stop blethering now, but that's a great question.
We're going to need to move along. I'm going to close that loop with something Peter Lawson said to me recently, which really got my attention, which is, how do we document the decision not to do something? Because when things go well, sometimes you can't go back and necessarily figure out you chose not to do something. So these are all very important questions to ask ourselves. And I'm glad you said that, Paul, sort of taking us into the next generation. How do we go forward with using monitoring, not out of fear, but out of predictive validity of wellness, which I really like. And in that, I'm going to now introduce you, Paul. Paul is going to talk about another topic that has an incredible amount of individual practitioner preference, and that is the management of junctional ectopic tachycardia. So I'll turn the mic over to you, Paul. Thanks.
All right, thanks. And when you offered, when Neil was not online, I should have taken you up and gone first, because God, I hate following Neil on anything that is a speaking engagement. This is not a good idea, but I'm going to try. So when it comes to something that over the years has done nothing but create dogma, I would say that JET is absolutely it. I have nothing to disclose. I thought, why don't we take a real quick step back and just sort of look at data versus dogma. So first of all, as the English literature major of me, reminder that data is the plural of datum, that data is actually a plural word. They are facts and statistics collected for reference and analysis, things known or assumed as facts, making the basis of reasoning or calculation. Whereas dogma are principles set forth, laid down by authority as incontrovertibly true, something held as an established opinion, a point of view or tenet put forth as authoritative without adequate grounds. I will resist every inch of the urge in my body to make political statements about the current state of US politics and media based on this, because I'm not going to get myself in trouble, I swear, but I will just leave that as it will. So, what I also love is that antidote plus anecdote is not equal to data. But opinion plus opinion actually is equal to dogma, right? So let's remember that, because we're going to come back to it when it comes to this talk. So what are the data about postoperative, specifically postoperative, not congenital, junctional ectopic tachycardia? It is the most frequent hemodynamically significant tachycardia in the postoperative setting. The hemodynamic instability results from a loss of AV synchrony and extreme tachycardia. It usually occurs within the first 24 hours after the operation. The incidence, depending on which reference you look at, and my last slide is going to be nothing but a list of references for people to take a look at. So I didn't include footnotes on each one of these, but the incidence is anywhere from 5 to 20%. And the mortality can be reported as high as 14% in one study. The diagnosis, strictly speaking, it's a heart rate greater than 170. The QRS morphology is similar to the sinus rhythm QRS complex. There's AV dissociation, and the ventricular rate by definition is faster than the atrial rate. more data. The precise mechanism is not known, but I will take speaker preference and blame it on the surgeons. It's some
Paul, can I ask you to stop for just a second? There's a number of comments coming in that the screen is blank. I see it on mine. I'm not sure why that is.
Huh.
That's typically a bandwidth problem. Grace, we usually recommend logging off and logging back on. Is that correct?
That's correct. I can see the presentation, so probably it's because of the browser. Close the browser, close the app, and then open everything again. The presentation will be there, hopefully.
Thanks. Paul, when I'm on multiple life support systems at the end of my life, would you please turn everything off and then turn it back on again and see if that works?
I mean, that's called every Miami meeting we've ever been at together, by the way, Gil. So you don't want me to turn this off. You're talking about the people looking at
the
it.
People who are having, yeah, the people who are having trouble with the Zoom.
Yeah. All right. So I'll go back to the mechanism then. And the reason why I say that's within the surgeon's realm is that there's some incidents of, or some suggestion that there's mechanical trauma, whether it be the stretch injury. However, it is important to know that it also occurs in patients in whom surgery does not involve any of the areas around the AV node. The risk factors are younger age of the patient, the duration of the surgery, basically bypassing cross-clamp time, electrolyte disturbances, the use of inotropes, and that's including milrinone, and the type of surgery. Prevention. In order to prevent it, there's an avoidance of hyperthermia, minimize inotropic usage. Some people advocate giving magnesium at the end of bypass, and some people use propranolol prophylactically in higher risk, which would be tetralogy patients. Now, in terms of management, and if it's there, if it comes up, optimizing sedation and pain control. And in significant cases, most series follow a sequential order of atrial pacing, hypothermia, and then anti-arrhythmic drugs like amiodarone and procainamide. Now, but I will note that this has undergone considerable changes over time, with amio now being preferred in several centers as your absolute first or second line option. Some sedation specifics. This is just one reference about the use of dexmedetomidine in the prevention and or treatment of JET. There are plenty of studies about both prevention and treatment. This yet again adds to the perception and the dogma that dexmedetomidine is God's gift to the postoperative cardiac surgical patient. There is some truth to that. It certainly does work, and I'll get back to that in a little bit. Specifically about amiodarone, it has become an early option. I want to stress it has to be respected as a medication. I have witnessed fellows doing the best job they possibly can who have induced significant hypotension leading to resuscitative efforts because of bolusing the drug. One of my old mentors, Zahava Noah back in Chicago, instilled as me as a fellow, you can always give more, but it's hard to take it away once you've given it. So small boluses, repeated boluses is much better than one big bolus. You just have to break the cycle. There are other reports of other drugs, and these are all found in the references at the end. And there are rare reports for the need for ablation. So a summary is that the incidence of JET has gradually declined over the years with improved surgical techniques, preventive measures like minimizing inotropic use, and avoiding hypothermia. So again, going back to these two equations, I want to add a third equation, which is, does 10 years of experience plus 10 years of experience equal data or dogma? And I think this would be an interesting hour-long grand rounds in and of itself. I would say that that's probably a mix of both, obviously, that there is something to be said for years of experience, but it's also something to be said for writing down the years of experience, because then it turns into data. So a provocative statement for discussion when we enter the dogma area. This is a quote actually from a surgical colleague. JET is a manifestation of a heart that has not been cared for well in the operating room. He goes on to quote that it's basically a heart that was beat up. I don't do the operation, so I take him at his word. But here is how I look at the treatment, and this is purely dogma zone. Management should reflect pre and intraoperative technique adjustments and exquisite attention to detail in the management of low cardiac output in the initial postoperative period. This is pure team approach in order to avoid it, and then treatment. If JET reflects cardiac output impairment, the greatest threat from JET is further impairment of cardiac output through AV dysynchrony, creating a negative feedback loop. This is the classic negative feedback loop that we have to break. Atrial pacing is the most effective measure for breaking the negative feedback. And the only reason to give amiodarone in my mind as I treat JET is to slow the heart rate down in order to capture pacing benefits. Everything else is secondary. If your JET rate is 190, you need to slow that down so you can pace atrially and get control of AV synchrony, and then thereby improving cardiac output. Dexmedetomidine and other sedation improves DO2, VO2 matching by lowering the VO2. I believe that dexmedetomidine in that setting improves myocardial energetics. And it also does provide some afterload reduction, thereby improving cardiac output. So after AV synchrony, the only other thing to do in the treatment of JET is provide excellent CICU care and move them along and maintain their cardiac output to stay out of that negative feedback loop. As I said, here is the list of references. I believe this will be easily seen through the just pausing the YouTube video at the end of this. There's no one that's better than the other. I would recommend sort of picking a few and diving in. And at that, I will stop my share, and I think we got back a little bit on time.
Paul, thanks. If I could ask you a favor, Paul, if you could maybe shoot me a text with any type of poll question you'd like to ask the audience now that you see the way it works in terms of what our audience does for JET. Do they use a stepwise approach? Do they use a battleship approach, et cetera, or any other things that you have? And again, I would urge the audience, if you have something that you think we would like to ask 700 people, when else do we get this opportunity? So let's suggest doing some of that, because I can do that offline. I'll open this up to some of the panelists here, and then we're going to go for a very short break. And I don't know if Melissa Jones and or John Costello are here. And if they are, just let me know and then we can introduce you.
Gil, I would just...
John, go ahead, Laura. Any comments on that? You guys work together. Do you agree all the time?
No, but I agree on, I mean, on the therapeutic side, I think I would really remind everyone of the caution with amiodarone. It is an effective drug, but not in the way people give a bolus in an ambulance, for example. And I think many of us, if we're honest, have seen children almost die or end up on ECMO because of what I would say is a too fast bolus of amiodarone. So we would give it slowly over 1 to 2 hours, and at the same time control temperature and take away other factors that may be exacerbating it. It works, but only if given very judiciously.
A couple of comments. Number one, I agree. It's funny. In one of the very first PCICS, I remember standing up arguing that amiodarone was the best drug for JET. And 10 years later, I stand up in my own institution arguing that procanamide is the best drug. I think that one of the things that I've done in my practice for many, many years is that if you ask a fellow or a trainee what the dose of amiodarone is, you're likely to get the dose for VFib or VTAC, which is 5 milligrams IV push, 5 milligrams per kilo IV push. And I've seen them push that in JET, and we've all seen that disaster. Consequently, I have taught for many years that the dose of amiodarone for JET is 2.5 milligrams IV over a half an hour. It just as a cognitive trick to disassociate it from the VT dose. And the only time I would ever push amiodarone anymore is if it's in my hand. The syringe is in my hand.
I completely agree. And I think that Both of those echo the same point, which is if jet was an emergency that needed a push, we would probably also be shocking the rhythm or doing something else. In other words, it's the negative feedback loop of persistent low cardiac output that needs to be fixed. It doesn't need to be broken immediately. And therefore, once you look at it as an urgency rather than an emergency, it changes that view as well, I think.
So since John Costello has just jumped off, and I'm going to catch him off guard with another person who's been through different practices, different dogma, I'm going to turn the slides over to you as soon as you answer this question. But
okay.
What is, as you've moved through Chicago and now South Carolina and other parts of and Boston, how has your management of jet changed? And what do you think about how we as a field can move from data to dogma? And Erica Malacher-Kirsch just sent something in the chat box, which is that there's a single center randomized trial that's going on right now. How can we leverage a society like the Pediatric Cardiac Intensive Care Society to answer these questions more quickly?
Well, thanks, Gil. It's a great question. And my practice certainly has evolved. When I was in Boston, I was trained to manage jet by Ed Walsh and his team. And the usual practice there was a combination of cooling and procainamide. Amiodarone was largely banned from the institution. Chicago, and the practice with Barb Deal and her EP team was the exact opposite. Big fans of amiodarone. We couldn't even get procainamide or Napa levels in a quick fashion. Here in South Carolina, the amiodarone is also the usual approach with the EP team here. So there's definitely practice variation among the institutions, and both approaches seem to work quite well. Not to mention many of the other things that the other speakers have talked about, adjunctive approaches with keeping electrolytes normal, minimizing catecholamines. Those practices were the same. So definite practice variation among institutions. And I think educational sessions like this way are one approach for people to realize that there's a different way to skin a cat to get to the right endpoint. But I think that the real way to get actual data would either be through an organization, say like the Pediatric Cardiac Critical Care Consortium or PC4, where very granular data are captured for all CICU counters, including surgical counters. So that may be one approach to solving that problem. And then, of course, another approach would be a large multi-center randomized clinical trial, which would be obviously be the gold standard, but is a challenge these days. So maybe what we need to do, as I think about this some more, is combine those two approaches and do a not a conventional randomized trial, but do a trial within a registry, and which should be much more cost effective than trying to do a traditional randomized trial. So that maybe be the ultimate solution to getting more evidence-based information, getting away from the dogma.
That was my trying to be smooth segue into the PCICS, which is the slide. Can you see that slide that I put up?
Yes. So
good. So I'll just introduce John. For people that don't know John, John is a cardiac intensivist now in South Carolina, but has been in Boston and Chicago, as you've heard. He is the president of the Pediatric Cardiac Intensive Care Society, which began in 1996. It's kind of hard to believe. And the incoming president, who's also in the call, is Melissa Jones, who's just a fantastic nurse practitioner who works here in the cardiac ICU at Children's National. And we thought they've been very nice and very supportive in helping us work through the academic process and how to best get cardiac intensive care out through the Congenital Heart Academy. And I thought we'd give John and Melissa a little bit of time to explain to you a little bit about PCICS. So John and Melissa, go ahead.
Well, I'll start off, Gil, and thank you for that introduction and for giving us a few minutes to talk about the Pediatric Cardiac Intensive Care Society. I'd really like to congratulate you and the other speakers for an outstanding session, and I think taking advantage of the unfortunate circumstances of this pandemic to revolutionize some of the educational approaches to pediatric cardiac intensive care. The Pediatric Cardiac Intensive Care Society is heavily invested in education. It's a multidisciplinary society that not only includes physicians, but nurses, physician assistants, trainees, and so on. So we embrace input and have membership from all disciplines that are involved in the care of children with congenital and acquired heart disease. And I would just like to, I see there are over 700 participants on this call. I would encourage you to go to the PCICS website. There are many benefits to being a member, including discounts on our educational products that are geared towards trainees, geared towards nurse practitioners, bedside nurses. There is information you can find there about the podcast that we've been hosting recently, which are quite interesting. There are discounted registration fees to our annual meetings. There's other courses that you can participate in. So the society has really evolved quite a bit in the last decade. And it's been really an honor to be having an opportunity to lead this organization, particularly during these interesting times. We have a big meeting coming up this winter, and if Melissa, I can't see it, or Melissa, are you logged in? Would you like to tell folks about the our meeting this December?
Sure, thanks. Yeah, and thank you. Oh, go ahead, John.
I was just going to say, for those who don't know, Melissa is the Vice President of the Pediatric Cardiac Intensive Care Society, and will take over this coming January, for me as president. So it's a honor to introduce you to her. And Melissa, go ahead.
Thanks, John. And thank you to Gil and Grace and Sasha for organizing these really outstanding webinars. This is really an honor for us to collaborate with you. So just a quick word about the PCICS meeting. Like many of the meetings this year, we are going virtual, but we are really, really excited about the content that we've put together. Lindsay, Justice, and Nikhil have led our program committee, and they've really stuck to the original content that was planned, and then added some content in response to some of the events recently in 2020. So there's going to be a session on COVID, and then another session on some racial equity issues. So in addition to our 2-day meeting, we'll also have a day of pre-conferences, which look like really quality content. So now that we're virtual, the downside is we don't get to see each other in person, but the upside is that hopefully we'll be able to reach more people around the globe. So again, Gil and the team, thanks so much for giving us this opportunity.
All right, I'm going to see if I can stop the share here. Oh, good. Melissa and John, again, thanks for your support of the Congenital Heart Academy, and we're looking forward to ideas for future webinars, not only from the Pediatric Cardiac Intensive Care Society, but all of the attendees here. There is a survey. Grace, if you don't mind putting in the chat the link to the survey again, so people can do an evaluation of this course. And if people have ideas for topics and talks, that would be fantastic to put into that survey. I see that there are 42 questions in the Q&A, which is fantastic. So if the panel could sort of jump into those, we can post-process them and get them out as part of our educational mission. Laura, I forget, am I next or you? You, okay.
I think it's me, Gil.
Good. Paul, send me that stuff, and I will take care of getting a new slide put out to everybody. So now it's a pleasure to introduce Laura Shekardimi, who's the Chief of Critical Care Medicine at Texas Children's Hospital, which I think is on its way to becoming the 51st state of the United States. There's a 21, is that how many stories? 21 story cardiac hospital. It's mind-boggling. So Laura, really looking forward. You've done some really seminal work in ventilation of these kids postoperatively and how these kids do over the long run. And I'm really interested in hearing your talk on how we should manage babies with tetralogy of Fallot, data versus dogma.
Thank you, Gil. Hi, everybody. It's great to be here. I'll just switch to my screen. Okay. Hopefully that's looking good. So I've been asked to talk about postoperative care after Fallot's tetralogy repair in infancy. And I think this is, you know, my approach. Hopefully many will agree with a lot of it. And I'm hoping that some of you will disagree with some of it and have a good discussion. Okay. So basic principles. I hope that if you take 3 things away from my talk, first will be that diastolic right ventricular function, it should be our focus. Kids do not come out with systolic dysfunction that should be of major concern in the ICU. And really, for us as intensivists, obsessive avoidance and recognition of factors that exacerbate this should be routine. Please note, and I think this sort of carries on from what Neil was beautifully sort of discussing, good intensive care doesn't mean unnecessary invasion. And in a similar vein, an extubated patient in infant is still an ICU patient. So the first thing is, what do I need to know about a patient that's coming in, a child after tetralogy repair in infancy? A handoff is a really important part of intensive care for the ICU team. And there's certain things we really need to know about our patients. The pre-op factors, so what was the anatomy, what was their prior palliation, if any, were they on beta blockers? And this can be quite relevant in the post-op course. And also non-cardiac conditions, syndromes, things that might impact our weaning and potentially extubation plan for the child that comes to us intubated. Anesthesia, were there any issues getting the patient to sleep, anything we need to know about the airway, and what drugs did the patient get, is the patient still on, and what vasoactives and why. And rhythm issues. Paul's talked about JET, and really JET is, Fallot is one of the lesions, I think, where JET is seen most commonly in our practice. And what about the surgery? What was actually done? What residual lesions? Was a transesophageal echo done? And if so, what did they show? And wires into pacing. And for the whole team to decide is, if this child is still intubated, what, if anything, should preclude early weaning and overnight extubation? So why does this all matter? I mean, after all, infant tetralogy repair is a success story. This is our program's data from PC4 with no mortality in over 150 infants. And similarly, very low rates throughout the network, same with failure to rescue rate. So why does it matter? Well, I think the reality is that while mortality is fortunately almost non-existent anymore after repair, morbidity continues. And I'm just going to touch for a moment on arrhythmias as one of the #1 issues we see after Fallot's repair. We're the center in blue, and this is the PC4 overall data. I'll give you a few words about JET. As I said, Paul has already told you everything there is to know, but really when children have diastolic dysfunction, the loss of AV synchrony can be very significant in these patients. We do feel that the incidence or impact of JET may be falling, and perhaps that's because we're more proactive in the care. We do use less catecholamines, we avoid hypothermia. Really, as for so many things in intensive care, early recognition and aggressive treatment have really helped us with this. And this means temperature control, avoiding exacerbating factors, and the judicious use of amiodarone. And I would throw out there, as Paul again alluded to, that perhaps the increased routine use of Precedex, dexmedetomidine in many of our centres has perhaps controlled the kind of urge of the patient to go into a tachyarrhythmia. What about other complications? This is again PC4 data. I'm sure it's very representative of many of the units amongst our audience today. A low cardiac output state really complicates about 1 in 10 or even more patients early after repair. Now, the low output state is a vicious cycle, and I would say to you that all of those columns that were on the previous graph and many more all kind of interrelate in a chaotic sort of way and further exacerbate the low output state. So we see cardiac arrest, ECMO, effusions, prolonged stay, prolonged ventilation, some of the other complications like sepsis and CLABSIs. They'll all be part and parcel of this vicious cycle that we try and avoid. If not, we try and act very early in our patients. And one of the key, I'm not going to show many publications at all in this talk, but one of the earliest and really, I think, most seminal paper looking at the low output after Fallot's repair came from the Royal Brompton Hospital in the mid-1990s. And I was a very young and bright-eyed and bushy-tailed research fellow at this time, working with Shay Cullen, who wrote the paper. And he observed and then looked hard at the reasons why some patients after Fallot's really got sick in the ICU with high filling pressures, a long ICU stay. They seemed to need more and more inotropic support, became waterlogged with fluid, and potentially had significant post-op morbidity and even mortality. And he looked he focused his research on looking at the diastolic performance of these patients. Why do they get this sick? So patients with restrictive right ventricular physiology after Fallot repair, so this is diastolic dysfunction, have abnormal but very useful to them forward pulmonary arterial flow here in the pulmonary artery, coincident with atrial systole. That's an important contributor towards their total cardiac output. And you can see here that when patients are spontaneously breathing with this restrictive physiology, they actually get a boost in their forward pulmonary arterial flow. So although this flow is abnormal, it does appear to be an important component of their cardiac output. So what does this mean for our patients? It means that if they're able to spontaneously breathe, they will preserve their cardiac output. Can we treat diastolic dysfunction? I don't know that we can treat it in the ICU, but we can definitely make things worse by ignoring it, or we can improve the post-op course by respecting it. The first thing to do is not to confuse this low output state with much more typical systolic dysfunction that we might see in other patients after congenital heart surgery. They do need preload, we keep them well filled. Be completely obsessive about maintaining sinus rhythm. And when it comes to ventilation, I've shown you that cardiac output improves when they're able to spontaneously breathe. So in these patients, early extubation certainly is an advantage if we can do it. It improves their cardiac output, and following on from this, these patients progress much more rapidly after surgery. We can wean their ICU support more quickly. We can get rid of lines and drugs that I truly believe most of them don't need, feed them earlier, definitely reduce the cost of charges depending on the systems we work in, and potentially, but not necessarily, reduce their ICU length of stay. So when we're thinking about early extubation, it's all very well to just talk about it, but it has to be very well planned, and analgesia and sedation are the mainstay of getting this right and having a patient ready for extubation either in the operating room or early in the ICU. So this means no muscle relaxants, avoiding opiate infusions, minimal benzos, and we almost routinely now use patient or nurse controlled analgesia, usually with morphine. We use a lot of non-steroidals in our patients, and as I've hinted at before, increased use of Precedex has actually facilitated early extubation because you can extubate a patient who is comfortable on a low dose of Precedex, and they will still wean, but they'll be less agitated and much more cooperative. So the practical aspects of early extubation, it really has to be in the surgical and anesthesia plan from the get-go, from the initial timeout in the operating room. Obviously, a kid needs to be reversed and with good respiratory effort. We wouldn't advocate for early extubation if there's major hemodynamic issues, rhythm issues, bleeding, this sort of thing. Gases don't need to be perfect, they just need to be good enough. X-ray in the lungs do need to be good without any surgical concerns. And you need a robust analgesia plan. Sorry, this keeps jumping around. And just to reiterate again and again, an extubated patient is still an intensive care patient. He or she requires obsessive observation and very intensive care. It can be done. We've done it in our institution, and many others have done similarly. It needs to be protocol driven. This was a study that I was involved with the Pediatric Heart Network, where we did a collaborative learning protocol to introduce on-table or early extubation in the ICU tetralogy of fallow repair. And you can see here that after introduction of a collaborative protocol, nearly 3/4 of all patients who entered the intervention arm were able to be extubated successfully without reintubation. But if you look at the bottom two graphs here, look at the impressive reductions in need for opiates, benzodiazepines, and Precedex. And if we think forward, these children are all going to be at risk of neurodevelopmental impairment. This is a really big win for an early extubation approach. And similarly, when we think of nutrition, the time to first enteral feed was much shorter after introduction of the early extubation protocol. So just one slide on access and monitoring. Neil has talked about it beautifully. What do I find useful? This is after Fallow's repair. An art line, the central venous line for sure, for monitoring for vasoactives, but get rid of them as soon as possible. Peripheral access, obviously, for other infusions, blood products, and remember, don't use CV lines for transfusions. If you're as worried about as we are about CLABSI, just transfuse peripherally. LA lines, we see them in a lot of our patients. Personally, I don't find them very useful. Perhaps I'm in a minority, but I think in a child with good left-sided function, non-complicated surgery, I think that number is relatively redundant, and we typically take them out the first post-op morning. The NIRS, I just go with it. I'm old, I'm an outlier at TCH, but certainly all our patients will come out with 2-site NIRS. Peritoneal dialysis catheters, we used to in our practice. Once we did the collaborative learning protocol, we stopped using PD catheters as a routine, and we almost never see them in patients that have had straightforward surgery. And just along the hospital-acquired infection line, urinary catheters, we take them out the first post-operative morning. So this is me. I've gone from that person to this person in the time represented on this slide. So when I started out, typically, tetralogy of Fallot was operated on well beyond infancy. The mortality was potentially up to 5%, and the intra-op management was very, very different to what we see today. Post-op management was sedation, positive ventilation, catecholamines, dopamine, dobutamine, you name it, they were all there. And the low output state was very common. I've learned a lot in the last 27 years, and I'm sure many people who are my contemporaries or even younger than me have learned a lot too. Now we operate, most of them under a year of age. Many centers do true neonatal repairs with a mortality that is almost zero. And the intra-op management is very different, and our post-op management is now preemptive. We target diastolic dysfunction, we use short-acting sedation, we do early extubation, and we do our best to advance them fast through the ICU. So my approach in 2020, hemodynamics, be obsessive about diastolic function. I'm really not a believer in targeting numbers. My fellows get sick of my hearing that don't target the blood pressure, but it's okay, a higher CVP may be okay in these patients. Avoid tachycardia, maintain sinus rhythm, and again, an LA pressure I don't personally find terribly useful. I think it's fair to say vasoactives are actually very rarely indicated, but 100% of patients in most institutions will come out on something with zero data to back it in this population. Milrinone is part of the umbilical cord that remains to be broken. Catecholamines, we typically avoid them. They are chronotropic and clearly only very rarely necessary. And I don't know about the rest of you, but esmolol seems to be becoming a new holy grail in many centers. And I'd love to hear what other people's experiences institutionally with esmolol. We tend to see children come out on it, so it's not typically started in the ICU. Analgesia and sedation, short acting and patient or nurse controlled. Let them breathe early, progress them early, but remember, an extubated patient doesn't always mean a stable patient. Thank you very much for me on this.
Thank you so much, Lara. If I could ask people to log back onto our poll. You said a couple of things during your talk, Lara, so I was furiously typing to get a few more questions in that I thought were interesting, and then we'll maybe open this up to the panel. But if everybody remembers, if you could type into ahaslides.com backslash CICU, all capitals, CICU 1. And the first question that I put out of interest is for patients who have an uneventful repair of tetralogy of Fallot, we usually extubate in the operating room within 6 hours of arrival, somewhere between 6 and 12 hours the next morning. I'm going to ask everybody again, if you can pick up your phone or another way for another browser to log back onto ahaslides.com backslash, and then in all caps, CICU1. And you should be able to see this on your phone. This has become an interesting practice in many places. So I thought that we would sort of get, and then maybe Laura, you'll be able to comment on this. And maybe somewhere in there talk a little bit about a cuirass, and do you still consider using that in selective patients with restrictive RV physiology? So we have 9 more seconds. I'm sorry, Grace?
Are you sharing your screen already with the questions?
No, I think people are looking at it on their phones. I will share my screen. Thank you for reminding me, Grace. There we go. So we can try again. We'll give people a little more time. So we have, of all of us on the call right now, we only have 180 logged in. So we'll give you a few more seconds to log into ahaslides.com backslash CICU. And if people would like to answer this question, looks like we've sort of reached the max here. A couple more are coming in. And Paul was kind enough to send me a question about JET after his great talk. And you know, we at the Congenital Heart Academy have not used this audience poll question. I've certainly been in debates where they ask people to raise their hand, and it's kind of hard to know. This is sort of a fun thing to see what people think, maybe even before and after a talk, to see if there's changes in people's minds. So we're looking like about 2/3, well, certainly almost 3/4 do this in the operating room or within 6 hours of arrival, which I believe is the standard definition of early extubation. Between 6 and 12 hours, I'm surprised it's this much. There are many units that wouldn't do that because it's quote on the night shift. And then we have the next morning. So I'll move to the next question, which is, this is interesting to me. Transfusions through central lines. I never use a central line to transfer, or no worries, or only if absolutely necessary. Because when you said that, Laura, I was sort of taken aback a little bit. So let's see what, we only have about 22 people on so far, but this was something, to be honest with you, I have not thought about. Do you want to comment on that while people are answering, Laura?
We are obsessed with CLABSI in our hospital, and you know, for good reason. We've had good years and less good years. And
CLABSI, for people who are not familiar with the abbreviation?
Yeah, central line associated bloodstream infection. So it's a hospital-acquired condition. It's taken very seriously in the US for good reason, because, it's taken very seriously for good reason, because it obviously impacts ICU stay, hospital stay, potentially even survival in some groups. And one of the very clear messages from the kind of the bodies that provide recommendations, and it will be the same, I think, globally, is that blood transfusion into central lines can significantly increase the risk of central line associated infection. So in our institution, we have a kind of checklist of things not to do with kids with central lines, and almost top of the list is transfusion. It's particularly packed cells, but we just try our best to avoid blood products. And I think in the operating room, it's relatively routine for, you know, big saphenous IV to be used. Obviously, we use a central line if there's no option, but it would not be our number one approach.
It's interesting, the results of this. And if you and Texas Children's wouldn't mind sharing that list of things you don't do in central lines, maybe, yeah. I think the people would really appreciate that. And then I have, this didn't really come up, and it seems like I can't advance my slides here. Hold on. I'm going to go back one. Okay, let me do this one first. So Paul asked me to ask the audience, how soon do you use amiodarone for a postoperative patient with junctional ectopic tachycardia? And I've seen all approaches from baby sick, has junctional ectopic tachycardia, gets sedation, paralysis, dexmedetomidine, cooling, and amiodarone, all at the same. And then I've seen a stepwise approach and a place where people don't use amiodarone at all. So the last one there is only 2 people who never give amiodarone. Others look like they wait and see if it's going to change things, and then only after I've exhausted other options. Thank you for sending that question in, Paul. Is this the kind of answer you expected?
Yeah, exactly, actually. Yeah.
Super. And then I think I had one more maybe. Yes. So Laura, we talked a lot about restrictive physiology, and Sasha said something before about always leaving an ASD. This evolved out of the practice of sick right heart, like the fenestrated Fontan. I know in my own practice, if I see a baby come out of the OR, and they're a little bit desaturated, shunting through the right atrium to the left atrium, at least I know their left ventricle is getting filled. And we're getting about equal numbers of essentially always and never. Yet another example of dogma rather than data. When you see both ends of a bell-shaped curve like that, it generally means that we've seen things only in one way. Well, that was interesting. All right, I'm going to.
Yes, Gil, but sorry, it's you remember the sentence, it's better blue than gray sometimes. Eh?
Well, you're not going to get an argument from me, but
I love
the 25
I totally agree.
The 25 people who said never, this will be the topic of yet another one of the Congenital Heart Academy's future discussions, I'm sure. Thank you everybody for doing that. We're going to post the results of this on our YouTube channel as well as send it out afterwards. Again, I remind the panel, excuse me, the panel that there's some questions that need to be answered. Grace, I am running out of power. I need to plug in. Would you mind going next with TAPVR while I find myself?
Amazing. Okay, I can do this.
Thank you.
Okay, so hi everybody. So I'm going to talk about the neonate with obstructed total anomalous pulmonary vein return. And we all know that we have 4 types of TAPVR. And just here is a paper that I found with a very good cohort, more than 400 patients, just for us to remember the types and that the amount of patients who has obstruction. And we see that in all groups of patients with obstructions, we have around 20% of mortality, and a lot of them requires ECMO. So this is an anatomical example of a kind of obstruction on the supracardiac type. And here on this angiography, we can see an infracardiac type that we have. We can see here better an obstruction when it enters the portal vein because of the closure of the ductus venosus. So the pathophysiology, we all know we have pulmonary venous congestion because of the obstruction. This is going to cause impair in the gas exchange. We have a decreased pulmonary venous return to the left atrium, and because of that, we're going to have decreased cardiac output. We have obligatory right to left shunt, and this is going to cause cyanosis. And most of the times we deal with a neonate with profound cyanosis, pulmonary hypertension, and hemodynamic compromise. So what to do with these patients on the pre-op care? So this is through a surgical emergency. What we have so far, we give this patient sedation, neuromuscular blockade. We ventilate this patient in the best way that we can. If none of these works, we have always ECMO to try to stabilize this patient before surgery. And we have some other things that are really controversial, and then we can discuss with the panel later. Should we send this patient severely sick to the cath lab to try to stent the obstruction? Should we need to open the ASD? Is the ASD the source of obstruction and causing the low cardiac output syndrome? Usually not. We see a lung full of fluids with congestion, and we think about to give diuretics to this patient. But is this the best option? Because we have to remember the LV is unfilled. Should we give nitric oxide pre-op to these patients, or we are going to make this pulmonary edema more severe and is going to have more cyanosis on these patients? And about prostaglandin, I remember when I was a fellow of pediatric cardiology, I was taught that we could give to all cyanotic newborns a prostaglandin to try to make it better until we have the diagnosis, except when we suspect of TA PVR. Is this still true? Well, we have not a good amount of publications, but we have something saying that maybe prostaglandin can reopen the ductus venosus, and this can decrease the amount of congestion and make the patient actually to get better. And when you reopen or keep open the PDA, maybe you're going to have more right to left shunt on that level, and you're going to increase the systemic blood flow. Well, we have several ways to correct it on the OR, and this is not the topic of our conversation. But then when this patient comes back to us on the ICU, what should we be aware of? What we should think about this patient can have on the post-op care? Well, low cardiac output syndrome, pulmonary hypertension, supraventricular arrhythmias, and we always need to monitor for residual obstruction. So we talk about monitorization. I'm really a huge fan of LA lines for this kind of patients. So when this patient has hypotension, systemic hypotension, we need to try to find out what is going on. So the most common problem that our patients have on the post-op is hypovolemia. Then we are going to have a low blood pressure, but we are going to have low CVP and low LA pressure. This is easily to fix, just to give fluids and in a moderate way to these patients. But if we have a low blood pressure, but we have high CVP and low LA pressure, we should think about pulmonary hypertension crisis. When we have a loud cardiac output syndrome or cardiac tamponade, we are going to have high CVP and high LA pressure. To differentiate from both, this is something that I always recommend, is for you to have a point of care echo. You don't need to call the cardiologist from home. You need just to get used to which machine do you have on your institution, on your ICU, and just learn to scope and try to find out if you have something like that. Well, when these patients, they have low cardiac output syndrome, we know that they have a higher filling pressures. They need that because they need to keep the stroke volume, because this is a chronically unfilled LA and LV. They have very poor compliance. Then this inadequate LV filling can be exacerbated by pulmonary hypertension crisis, and this is going to make this low cardiac output syndrome even worse. Mirinon is often helpful to reduce systemic afterload and to relax the LV a little bit. Low-dose EPIC can try to improve contractility. We should administer volume with a lot of care to these patients, because the LV is non-compliant and the LA they are both non-compliant. These patients, they have to have a good heart rate, not too low, because we know that neonates depend on heart rate for their cardiac output. But we need to remember that as is a poor compliant ventricle, we should not have high heart rates. And should we keep this chest open, or should we close the chest in the OR? This is something that we should discuss. There's actually no data to support either. And we have to remember that we always have ECMO to support our patients. Well, when we have these patients, I usually say that we have a hibernating bear in our hands. You know, this patient should be on deep sedation, and it is interesting to see how everybody around the world uses this. In our institutions, we are using clonidine IV infusion and morphine IV infusion, and this works very well. There are some data to support that. And sometimes we need to keep this patient on neuromuscular blockade for 24, 48 hours. We have to give good ventilation, not hyperventilate or not hypoventilate. maybe it's a good idea to hyperoxygenate and sedate before procedures like suctioning or the x-ray in the morning. We should avoid fever, avoid acidosis, and use nitric oxide and Murinon. So when we are facing a pulmonary hypertensive crisis, we are going to see our patient first becoming tachycardic, then he can become bradycardic very quickly, and sometimes they have arrhythmias. He will drop the saturation if he has a PFO or ASD. I'm a huge fan of that. And he will drop his ETCO2 because the pulmonary blood flow is going to decrease. He will have features of low cardiac output syndrome, especially if we don't have ASD. And we are going to see on our monitorization, high CVP, low LA pressure, and low NIRS. And this can rapidly progress to cardiac arrest. And here we have dogma. That's what I usually do. And then it's good to see that we have some data to support it. It was published a guideline on circulation in 2015 about pediatric pulmonary hypertension. And they talk about the pulmonary hypertension crisis. And mostly is exactly what I usually do. So you ventilate with 100% FiO2, you give extra sedation if needed. You can modestly hyperventilate, but not too much because you don't want the cerebral perfusion to be impaired. And if you're going to do hand bagging, don't forget to use nitric oxide on this device, not to stop ventilation and get the patient without nitric. So bicarb is something that is controversial on the literature. They say it's a 2A I usually give on the crisis. And you should start nitric if you're not using yet, or maybe you can try to increase for a certain moment the dose that you are giving. You can support your patient with inotropes and vasopressors. We should always, when you have a crisis, call the ECMO team, be ready to go on ECMO because things can get bad, and you need to be ready to treat and arrest if it comes. Another complication that these patients can have is supraventricular arrhythmias. Up to 20% of these patients can have it, and you should treat it quickly and accordingly, depends on the type of supraventricular arrhythmia. And this is, Gil gave me these two x-rays that are really nice. So if after a couple of days, you don't have these bottom x-ray on your patient, if your patient is with sustained instability, you should try to find out what is going on. It can be a residual obstruction. So you can do it on echo and CT angio, but the gold standard is send this patient to the cath lab to see the hemodynamics and the anatomy. And if you find a residual obstruction, you should send this patient to the OR again to operate. So my take-home messages, and that's what we found in our textbook about how we should treat these patients on the post-op. We should monitor, we should sedate them, control acidosis with ventilation and bicarb, use nitric oxide, have a good volemia, give inotropes, reduce afterload, think about the heart rate and the heart rhythm. Consider vasopressors if it's needed, like vasopressin if you have a vasodilatory hypotension on these patients, and make the diagnosis if something is not going well. Use ECMO. Up to 20% of these patients needs ECMO on the post-op, the obstructed patients. And when we are weaning these patients, even after this initial 48 hours, we should be very careful because they can, when we are decreasing ventilation, decreasing sedation, they can have pulmonary hypertension crisis. That was it. Thank you very much. Greetings from Brazil and from the Middle East.
Thank you, Grace. Oh, hold on. Thank you, Grace. I was able to get my computer plugged in at the last minute, so thanks. We're already up to 10 of 3 on our time. It's been a great session while we've been talking. I'm just gonna, if it's okay with everybody, I'm just gonna move forward into the last one, which is a few minutes on transposition, and then we can wrap up, if that's okay. What I'm gonna try to do now is hopefully be able to share my screen, but I had to go to 2 monitors. Do you see this screen?
Yeah, we can see your presentation. Just need to go to presentation mode.
Yes.
Okay, and you can still see it, correct? Good.
Yeah, amazing.
So transposition surgery has been around for a long time, and now in the era of the arterial switch, there's quite a bit of institutionally specific practices, and I'll show you a few of those. And obviously we've had an entire webinar and there have been entire symposia on transposition. So I'm just going to briefly go through a few things about what we know and what we don't about balloon atrial septostomy, the pluses and minuses of having an open PDA on prostaglandin, the accumulating data about the timing of surgery, and the data regarding the postoperative course. You're all familiar with the circulatory pattern of transposition, which in the fetus provides desaturated blood to the head and saturated blood to the placenta. And as soon as the baby is born, if there is no communication between the atria or the ventricles, there's profound hypoxemia and rapid mortality. So when one creates an ASD or PFO with a balloon atrial septostomy, we allow for left atrial return to get from the left atrium to the right ventricle and to the aorta. And I'll come back to that point in just a second. But you need holes to get the red blood somehow out to the body. Now, we do know that the volume of blood that mixes from one side is equal to the other side, but in the current era, an atrial septum alone, atrial septal defect alone, generally gives low enough saturations that many in the ICU get concerned and will generally start prostaglandin. And what prostaglandin does is induces an aorta to pulmonary artery shunt predominantly, which is then balanced by a left atrial to right atrial shunt. So this is pretty much the only way that prostin helps. You don't mix at the ductus, but you get a lot of pulmonary venous return, which encourages mixing. You also get heart failure, just like any child with a ductus, whether they have transposition or not, or a preemie with a ductus. Ductuses are not good for your hemodynamics. So even though the oxygen saturation is better, you've now volume loaded the heart and put the baby into congestive heart failure. So again, I want to point out at the beginning here that all that matters in this disease, we've changed our thinking a lot about that, is that you have to get the left atrial blood to the ascending aorta. That really is only going to happen at the atrial septum. If you have a VSD alone, it's very unlikely that blood will go from the lower resistance pulmonary or LV circulation into the aorta. So most babies will need a ASD to deliver adequate oxygen specifically to the coronaries and to the brain. The PDA works not by increasing mixing, but by increasing filling. But that then brings up a lot of questions about what to do next. I had the pleasure as a medical student to be tutored by Bill Rashkin, who I guess didn't believe in the germ theory as he's doing this cath with no mask and a big grin on his face, but the pioneer of the balloon atrial septostomy, which I think he would be amazed is now done in most of our places under echo guidance here in the cardiac intensive care unit. So there are risks and benefits of a septostomy. It's mandatory in the neonate with transposition and intact septum and significant hypoxemia with a highly restrictive ASD. It does improve oxygen saturation. Does it improve oxygen delivery? We'll talk about that. It can decompress the LA if the LA is hypertensive, but it is invasive. You're going to go into the femoral vein of a kid. We'll talk about why that's problematic and why this has been associated with the risk of stroke. The data in large meta-analyses is a little bit mixed, so it's still somewhat controversial of the risk-benefit ratio of a septostomy in the baby that's not in extremis. And then what I've seen in a number of places is allow stabilization and time before surgery. The problem with transposition is that any vein is connected to the right atrium, the right ventricle, and then right up to the head. So really, it's not just the septostomy, it's any access that you have on the venous side can lead to stroke. There's a little air bubble as shown here, not that we try for that, and I'd like to use the expression vein to brain in this disease. About 80% of the ascending aorta flow comes from the systemic venous return. So anything that gets into the venous side can be problematic for the brain. So when we talk about the risk of stroke, is it the balloon atrial septostomy or the underlying physiology of TGA? Well, it's obviously both. They are co-linked variables. The problem with the septostomy is when you take out the 5 French sheath, say, the vein stops bleeding by forming a clot. And that clot may go somewhere untoward, like the central nervous system. So the risk of stroke is real in these patients, and it's contributed to, but not only due to, a balloon atrial septostomy. So what do we actually do? What is the data from the Pediatric Health Information Systems database? So this shows on the y-axis, the proportion of subjects who have undergone balloon atrial septostomy, and then the 30 or so hospitals that were in the study. And you can see it ranges from 20% to 80%, which is nearly identical to the poll results that we got at the beginning of this session. And when you look at other things on the management from this excellent paper, and I'll be happy to share that, is the wide variation in the use of prostaglandin infusions. You could see the standard deviation goes almost all the way down to 0 in this box and whisker plots. So that's 2 standard deviations at the top there. But on average, probably 2/3 of the patients will get a prostate infusion, about half will get a septostomy. Interesting that a third are ventilated going into the operating room. Inotropic support is rare. Very little data. The fact that we have this wide error bars shows us that there's not a lot of data to support our practices. I do know that most of the people that I've worked with over the years are much more comfortable with a SAT of 85 than a SAT of 70 to 72. And we hear this a lot. The baby is stable on a prostaglandin infusion, which I believe is a myth. The baby is in heart failure on a prostaglandin infusion. And this is a patient that was in our ICU about 2 months ago, who presented and needed an urgent balloon septostomy and developed necrotizing enterocolitis 48 hours later. So on day 6 of life, we thought, well, the baby has neck, let's stop the prostaglandin. And we did it at 3 o'clock in the afternoon. By 9 o'clock, the saturations were in the 60s. The PDA was restrictive, and the nighttime team reordered the prostaglandin, and the ductus opened at 10:30. And I show you this so that's the ediometry recording of IDO2 at the top. And I want to thank my colleague Craig Futterman for helping me collect this data. So under that, you can see the pulse oximeter went from 64 to 93. So, hey, that's great. Isn't that fantastic? But the other thing I want to point out is the heart rate went up about 15 beats per minute on average, which is what you would expect with a volume load from a ductus. The blood pressure widened from 26 to 39 in this patient that previously had neck. The cerebral nears went up, but the abdominal nears went down. So it's a double-edged sword. Where are you getting your oxygen delivery? Is it evenly distributed across the multiple beds? You know, what are we actually going to do about this? Prostaglandin is a double-edged sword. It's got its pluses and its minuses without question. We know this is surgical heart disease. We know an open PDA is not necessarily a good thing. So I want to quote the person who started this out, my colleague, John Berger, who has a number of commandments in the ICU. I think he gave us one that a vial of epi in the hand is better than 2 in the code card. But this is the one that I think resonates the best with me, is thou shalt not treat surgical heart disease with medicines. In my opinion, transposition physiology is tricky. It's dangerous. There's changes in the hemodynamics. There's unpredictability of all of the venous return and where it's going to go. On the other hand, and I've used this at our last talk, Sasha, you'll remember this. The arterial switch is good for babies with transposition. Here's an example. This brain is blue, and now this brain is pink. It seems quite simple to a non-surgeon. That's what's called the courage of the non-combatant. I'm the one who doesn't have to do the operation. And there's blue Sasha and pink Sasha. So what about timing of surgery? If we go back to the FIS database, this is data about the median age of the arterial switch operation on the left, as you can see here. And this is almost identical to what we got on our poll at the beginning, where the median is somewhere around 7 days and extends out to close to 2 weeks here and some down to 3 or 4 days. And there's a group in the Ukraine who's now using, we've been doing it for about 5 years, umbilical, Dr. Yemetz and his team, and they use umbilical venous blood to prime the pump and do the operation, which in the first 4 to 24 hours. It's fantastic stuff. In general, for the arterial switch and just about anything else, you can draw this curve. If you go too early, the mortality is higher. If you go too late, the mortality is higher. And I'll show you some data for this. You could draw the same thing for total veins, VSD, you just have to change the x-axis. And then the morbidity, as I'll show you, goes up as you wait. So the data suggests, I'll show you papers very quickly, that in the absence of complicating factors, low birth weight sepsis. The current date suggests that the optimal time is probably closer to 3 than 5 days, but certainly not 2 weeks if your system can support it. And the younger we get these babies to the OR in general, the better. This is some data from Columbia, a widely quoted paper from Brett Anderson and Emil Basha, who again see that inflection point at about 3 days of age. This was another paper that was reported in the World Journal of Pediatric Congenital Heart Surgery in 2014, where they found that hospital survival was 98%, but the length of stay was the low, and the total charges was lowest in group 1. Group 1 is the patients who underwent repair at 4 days or less. So in our institution, that's certainly something that we are striving for, again, in the absence of uncomplicating factors. And it was not associated with worse outcomes for any measure of morbidity. We do know in transposition that cerebral oxygen delivery falls daily. And that's an important thing to remember. So that so-called stable on prostaglandin baby may not be. This is data from that last paper on that Dan Licht looked at, where the saturation that he's using measuring optics, the blue bar is transposition. The saturation falls on a daily basis. That's 0 to 5 days on the bottom. Very quickly, in terms of postoperative care, good postoperative care begins in the OR. The first important assessment is the adequacy of coronary perfusion. That'll show up in the OR as difficulty in separating from bypass, but for us, it will be the documentation of ventricular arrhythmia. So the second thing after coronary perfusion, in my view, is the assessment of bleeding or hemostasis. The third thing is bleeding. And then after that, the fourth thing, and then we start to get into some other challenges like bleeding. If you don't get this under control, you can't take care of postoperative issues. And that's the most important part. And again, it's very easy for me to say this as someone who doesn't put sutures in anything, but there's a lot of stuff being done in a very small area that's shown there in that circle. And for the cardiologists and intensivists that don't get a chance to go into the OR, this is a preoperative view of a transposition. Just to show this again, that these are the tiny, this is the left coronary artery over here. If you get bleeding from the back over there, you can't just randomly put sutures in there. So bleeding is the most important thing. So we always hope that kids come up with good hemostasis. Individual centers will use delayed sternal closure or not. One of the most overshown slides ever is this postoperative cardiac output slide. We know this was actually studied in transposition. Now reported 25 years ago, did it about 30 years ago. We also know that PVR and SVR go up the first night. In the Primacorp study, which was 1/3 transposition, the mixed venous saturation falls at 4 to 8 hours. Larry Rhodes looked at arrhythmias after the arterial switch, and in the 10 days in the ICU after the arterial switch, just to remember this, 51% will have occasional ventricular ectopy and couplets in 10%, but a small number will get sustained tachycardia. Frequent PACs, frequent PVCs early after surgery, you've got to look at as a marker for coronary insufficiency. And then finally, the recognition that some of these kids have large collateral vessels. The first clue about that is when you speak to the surgeon and she or he says, there was a lot of left atrial return. You have to be mindful that there might be large bronchial collaterals, and if that baby is having trouble extubating or having difficulty progressing, to try to look for that. And this is a paper we published over 20 years ago now looking at this. A recent study on the same thing 2 years ago reported that about 15% of the patients with transposition needed coil embolization. It's clearly associated with a longer length of stay. And it's also interestingly associated, to my surprise, with a lower preoperative saturation. 20% of neonates develop acute kidney injury after the arterial switch operation. And again, all of these references will be on the YouTube, that you can look them back up. And in this particular study out of Southampton, 51% had AKI. So even though the arterial switch is good, it's still a tough group of patients that have a lot of morbidity in the perioperative period. The brain is one of them. And most of the seizures that occur after the arterial switch, especially if your patients are heavily sedated, are subclinical EEG only. And EEG monitoring at our institution and many others is now part of routine monitoring, continuous monitoring after cardiac surgery in neonates. So here's our roadmap or our flight plan. If a baby underwent an arterial switch operation today, we would be looking for a risk of low cardiac output tonight into tomorrow, some oliguria maybe in the first day or two. The risk of seizures tends to be in that first post-operative night, maybe a risk of arrhythmia, especially if there's a VSD. Due to the effects of cardiopulmonary bypass, we would expect a bit of thrombocytopenia in particular on the second and third post-operative day. And then the baby gets better over time as they have less irritability and pain. They pee better, they're extubated, and they start to PO feed better. If your patient doesn't follow the expected post-operative course, and this was drilled into me by Dr. Castaneda, Dr. Wessel, and many others, the first thing is that the disease is not dopamine deficiency or epinephrine deficiency. Just because you should turn up the epinephrine doesn't mean you know why you need to. So you have to investigate first, did the cardiologist make a correct and complete diagnosis? Is there residual surgical disease? As we've talked about, are they aortopulmonary collaterals? And then at the time of failure to extubate, in addition to collaterals, do we think about, is there a diaphragm paralysis or vocal cord paralysis? So in summary, what we know, which is mostly from descriptive postoperative studies, is that early repair seems to be better, somewhere in that early range of 3 or 4 days. There's a predictable low transient period of low cardiac output due to inflammation and ischemia and pulmonary vascular reactivity. There's a transient period of pulmonary dysfunction and a transient arrhythmia burden. And these are generally in the first few days, including renal dysfunction. And remember, please, this is probably out of all the lesions that we care for routinely, probably the most at-risk central nervous system, pre-op and also post-op. So what we don't know is the problem, and that's where we started. What are the relative risks and benefits of timing of balloon atrial septostomy, a prostaglandin infusion, routine peritoneal dialysis, which I did not get into, early extubation? There are centers extubating arterial switches on the operating table. What's the risk and benefit of elective delayed sternal closure and EEG monitoring? So I didn't give you any answers to those because I certainly don't know them. So I'm going to ask the panel. So a newborn arrives in your unit. It's a 3.6 kilogram boy who had a prenatal diagnosis with transposition, intact septum, who's spontaneously ventilating. Pulse oxes are good, receiving prostaglandin, and it's Wednesday at 4 o'clock. It's always Wednesday. It's Wednesday at 4 o'clock in the afternoon. What would you do? And then would you do anything differently if it was Monday? I don't know the answer to that. We talk about this sort of stuff all the time. And so because I like to pick on Paul Kecke, I'm going to ask him first.
Thanks. So you want the reality, or we know what the way this is going to play out? What I'd like to do is turn off the prostaglandin and then have him in the operating room by Friday morning. The reality is we will do a prostaglandin dance, and then he won't go to the operating room until Monday. And if it was Monday, honestly, it probably wouldn't be all that different. He'd be in the OR on Friday of that same week, but we still would probably do a dance. What I'd like, though, is turn off the prostaglandin and get him to the operating room within by Friday if it's a Wednesday.
You know, I made it on Wednesday on purpose. I've been at 2 centers where the obstetricians, for whatever reason, decide they want to do their cesarean sections on Wednesday for kids with heart disease. It like drives me crazy. Would you do it any differently as if it was a Monday?
The dance would be.
Let me ask you another question, Paul. Would you bump an elective tetralogy on Thursday because you've got a switch sitting in your unit on prostaglandin? I love that smile because you know this is what happens to us all the time, right?
I'm not doing this alone, Laura.
Now listen, remember he's stable on prostaglandin. Why would I bump a transposition, right? Or why would I bump a tetralogy? Laura, you want to chime in?
Yeah, sure. The reality is we've always got an empty OR almost 24/7, but we would not, You know, in our practice, we would wait till days sort of 4 to 7 to do a switch. And I think Paul missed out the fact that there'd be a pretty high chance of the baby getting a septostomy if there was any hint of restriction despite good SATs. And I think we're one of those centers. I said whatever the one below all the time was for septostomy in an intact septum.
And does for both of you, and then I'll ask John and Neil, how does the timing of surgery, which may or may not be under our control, affect the decision to do a balloon atrial septostomy, which has been associated with a 5% risk of stroke, which means you then can't go and get heparinized?
It's almost two separate things, Gil.
What do you mean?
Well, I think for us, you know, if surgery was truly urgent and despite the septostomy there was inadequate mixing or PVR issues, things like that, the child would be considered for an arterial switch that's urgent. Otherwise, it's not looked on in our institution, and many, I think, as a surgical emergency being needs to be done in the next 1 to 2 days.
It's interesting.
The child go on to the next year.
It's certainly that in most cases. Sasha, I'll get you in a second. In most cases, the notion that a transposition is, quote, stable is now being challenged by what's being learned about the central nervous system.
Absolutely.
I think what Grace presented is true. It's one of the true surgical emergencies with obstructed veins. But we somehow feel better with, we just did a septostomy, we're staying on prostaglandin to wait 5 or 6 days. And I get that. Sasha, you're the surgeon. It's Wednesday and your intensivists say, we need to do this Friday.
No, we have a Sicilian rule. If patient need prostaglandin, the day after need prostaprolin. So the day after, he do operation. This is something that we realize with the cardiologist.
I never argue with a Sicilian. Never.
No dents. Here, no dents. No prostaglandin dents. Only surgeon dents. But I agree. So in the past, like this.
So if the baby comes in on Friday morning and starts prostin, would you bring the team in on the weekend?
Saturday.
We have done a few in Philly. John Berger, what's your thoughts on
As you say, Gil, we realize this. If patient need...
I also want to, John, before you answer, let me ask Luciana what she's doing in Pittsburgh and what her practice has been in Sao Paulo with a baby born on Wednesday that has transposition, or a baby born on Monday.
Depending on the schedule in the OR, we would do Friday, but if not possible, so go to the Raskin and then postpone for the next week. I think this is the real thing that we would do. Mm-hmm. And I agree with you about the collaterals. The collaterals is an important thing, but in the OR, sometimes if you narrow the pulmonary arteries, you cannot see much of the flow coming after in the PAs. And this can be a big trouble in the postoperative care. We had a case in Sao Paulo a long time ago with a collateral coming from the neck. And it took a lot of time to discover that collateral and embolize, and the kid survived after, but it was a huge thing.
It's an interesting thing you said about the Wednesday thing is that it's the birthday lottery, right? It's a birthday lottery because if you're born on Wednesday, you're stuck because Saturday and Sunday are on the Greco-Roman holiday schedule. If you're born on a Monday, you may get the operation at an earlier time. John, what are your thoughts? You've been here longer than I.
Well, my thoughts are pretty much the same. You stop the prostaglandin, feed the baby, because we know that if the baby feeds before operation, they do better. And beat your head against the wall trying to get the surgeons to operate when you want them to.
Well, you can always call Taramina, it sounds like. It sounds like they'll do the operations at any time.
I don't wield the scalpel, so it's hard sometimes to force the issue. I do remember us sitting on transposition for over a week, because our one and only chief surgeon had jury duty. And he finally operated on the child at 4 o'clock in the afternoon after 4 days of jury duty.
How about Glasgow, Neil? What's going on up there? I think you're muted. Try again. Can't hear you. I'm sorry. Technical issues.
It's night.
So 2 days? You operated 2 days? Is that what that number 2 was?
I'm sure it was brilliant. It was absolutely brilliant.
Hey guys, this has been a lot of fun. There's so many questions, and so we've been on for a long time, for 3.5 hours. And I do want to thank everybody for almost that long. So, for some reason, my screen, Grace and Sasha, doesn't have the chat box or the participants or the Q&A. It's just the way I logged on, it didn't give it to me. So if maybe you and Sasha could close and give some information. I do want to just say briefly that I think we have set up these panels and these sessions with extreme sensitivity about gender and international diversity. It's extremely important to us that we do that. Our next couple of panels have just worked out to be all men. They will all mansplain to each other, but in all of the combined surgical program, there is much more diversity in that. And I'm responding to a number of appropriate emails that I got today. So I want to speak to the audience about that and be sure that we are taking this very seriously. Sasha and Grace, I'll turn this back over to you.
Grace.
Okay, just want to thank everybody. It was an amazing session. Please fill the survey, the feedback survey. It's going to be very important to us to see if you like this kind of session. I personally loved it. I think it was very interesting and we could learn a lot with this panel discussion. I'm very happy with that. And talking about what Gil just said, and we always try to have all the diversity, not because we really focus on that, but because we have amazing people from all over the world and from every gender. So that's how we make our panels. And for the next surgery one, we had Luciana. She was going to talk on that. She had a surgery scheduled. She's going to speak in the next one. This is an example that how we would arrange things. And so that's it. Thank you, everybody. It was an amazing experience. I'm sure it was great for you as well. Please fill the feedback survey and see you on Wednesday to talk about monitorization on CICU. Sasha?
Yes, Gil, thank you very much, because today we are trying to change something. I'm sure today with this type of poll, you are changing something. The things became very easy, very different, and very useful for people from around the world. I thank all the people, because in the chat, again, you can see from Argentina, Chile, Indonesia, and this is what I want to share with the people from panelists. What we are doing is make a big sense. So we are open to accept every collaboration, trying to help and support all the program all around the world. What you are saying seems to be normal for you, but for people that has not the privilege to come to a World Congress or in a Congress, these are big message. So thank you very much. It's a pleasure to be part of this panelist. Thank you.
Thank you.
Thank you.
Bye, guys. Thank you very much.
Bye.
Thank you, everybody. Enjoy the rest of your day. Special thanks to the people from Asia where it's 2 o'clock in the morning or something for staying on, which is terrific.
Bye, everybody. Thank you.
Yeah. Goodbye.
Migliaia di bambini stanno morendo in questo momento perché non hanno cibo.
Mm.